Morning. Um, please remember to keep your cameras on unless you have already discussed this with one of your supervisors. I hope you're doing fine. You're doing okay this beautiful Saturday morning. Welcome to our Texchip Integrated Care Behavioral Health Virtual Symposium of this year. So right now we're gonna start with the session from 10 to 12 by Dr. Curtis and Katie Goetz, and it's titled "The Mindset and Clinical Skills Needed to Thrive in Integrated Care." And I'm gonna let them introduce themselves and kind of like let you all know what this is gonna be about, but please remain with your cameras on and yeah, message me if you all need anything.
All right. Thank you for having us. It's a pleasure to be back. And I was talking about how I see that y'all are at 86 degrees. Katie and I up here in Asheville are at 68 degrees. It feels
Yeah.
like fall, very weird for August, but it's very refreshing and it's so nice to see y'all. I will be I will be monitoring the chat as well, so feel free to add stuff in there. And then also Katie's kind of driving the PowerPoint. Let's see, what else? Um, oh, I also wanted to make you aware, a couple things is Katie over the summer, she does a lot of adjunct teaching with us and she'll introduce herself, but does some adjunct teaching at Western Carolina University. And we this summer just finished up our class in positive psychotherapy and integrated care. And so we're going to share a little bit of positive psych information. But Katie was also gracious enough to create some YouTube videos, really kind of 5 to 6 minute YouTube videos of kind of the language to use with clients in integrated care settings. So I'm going to put my channel in the chat, and they're fairly recent ones, so you can find her pretty easily for how to work with severe and persistent mental illness, how to talk about medications with clients, and so forth. So just be aware that I love y'all's YouTube channel. I use it in
Mhm.
class. You've got a lot of great information. So if there's anything that we've created that you can use, feel free. And yeah, Katie, you going to pull it up there?
Yeah, let me get you going here.
I didn't realize this was yeah, here we go. Ah, okay, cool. All right. So just really briefly, the objectives, we want to kind of talk about the philosophical foundations of integrated care, but also give you some specific techniques. My hope is that when you leave this today, and if those of you who are working in the field or getting ready to do practicum or internship, you'll have some solid techniques that you can use starting Monday. Also talk about kind of the interpersonal skills that are needed to work well in integrated care. And then what I hope to do is to show just how a lot of our kind of basic fundamental counseling skills are already integrated in integrated care. So that's kind of our hope as we move through. And please, again, ask questions. You can post questions in the chat or just ask them out. Doesn't bother us to interrupt us. Maybe interrupt's not the right word.
Mm.
Oh, and I was thinking, Katie and I talked about yesterday as we were prepping some more, probably taking like a 5 minute break at noon. So go 1 hour, get our eyes off the screens for 5 minutes. That way, Katie and I can kind of huddle and make sure, like, hey, we've covered enough or that kind of thing. But I realize that we'll have some dead time on the recording, but just be aware that I think a 5 minute break to stand up, get away from the screen might be helpful. And that way, Katie and I can figure out where we are. All right. Okay, so this is me, and as you see, my two dogs, give them some love, if you will. Both of them are a little elderly and starting to experience some medical issues, and that's hard. But just a little bit about me, I was a business major at NC State University, and then worked to my master's in counseling at UNC Charlotte, and then got my PhD at UNC Greensboro. Cisgen 58-year-old white heterosexual male, first gen college student. and just using my privileges at this time to increase awareness of positive psychotherapy, also systemic psychopathy, which is maybe a controversial term, and I may share that a little bit later, but just kind of helping to see. I think we're moving out of it, but just how there may have been forces that have enjoyed and benefited from kind of manipulating us or making us feel small and fearful. And it's kind of new for me, and I'm diving into that. A couple other things. Now, I'll tell you, I'm having fun with this at Gen X, Pisces, the Enneagram 4, Hufflepuff, etc. I do think one of the most important things we can do in this profession, whatever we're specializing in, is to know about ourselves. And so I do think tests such as the Myers-Briggs and so forth and Enneagram, they're just catalysts for further self-exploration. And the more we know about ourselves, it almost feels like it frees up our energy so that we can be more present with clients and have what I think is more kind of a healing presence with clients. So I do this for fun to let you know a little bit about me, but I'm also hoping that you will continue self-exploration. Thank you.
All right, this is me. This is my pup here on the picture who spends a lot of time with his tongue out laying around. Um, my undergraduate was in English and theater. I have no idea how that happened, but always had a love for stories, which led me into counseling. And I'm originally from St. Louis. I'm the youngest of four girls. I've played soccer all my life, and I feel like that was a good setup for integrated care. As I was never the most skilled, but I learned to get the ball to people who were. And there's a lot of teamwork involved in integrated care. I also had a coach who used to say, "You're a player, not a position." And that has really helped me in integrated care as you just pitch in to do what can be helpful and paying attention to that. I have never read Harry Potter, so that is my confession for today. Please don't judge me on that, as Russ will. Um, and am always learning more just about my own inherent racism and that in our world, which certainly greatly affects people's health and healthcare. And just glad to be with y'all today, and feel free to use the chat for any questions. Yeah, excited to be here.
We should brag on Katie. Can I brag about you? I mean, first of all, just being so experienced and certified in CBT and EMDR and licensed clinical addiction specialists, supervisors, all that good stuff. But also, Katie's sister is the athletic director at Iowa. And so if you watch Caitlin Clark doing anything, you may have seen her like in the stands there anyway. So I think Katie brings that same leadership and kind of champion students.
Thanks, Russ.
You able to forward that slide or what's up?
Yeah, just give me a nudge when you need it.
Yeah, we're good for the next one.
Are you seeing the stop slide?
I am not. What do we have here?
Yeah, let me just reshare because it doesn't look like you're seeing what I'm seeing.
Yeah. But I believe we are on the see what I may do. I may go out and come back in. It seems like I'm having a little bit of a computer issue.
Yeah, are you guys seeing the slides? Sharon, are you?
Yes, I can see it.
Yeah.
Mhm.
Okay, I thought so.
I seem to be a little frozen, so let me kind of bug out. And Katie, if you just kind of want to run with yours, and I'll be right back on.
Yeah, no
Yeah,
problem.
cool.
This is the reality of technology, right? That it happens. I had a clinician call the other day because they had she works in an integrated care setting, but there had been a crisis call and their internet was all down and she couldn't get in to see the record. And it was this moment of like, how do I do this without the record? And she actually has more experience than I do. And I was like, do you remember you used to take crisis calls and you'd have no access to someone's record? And it was just that moment that I was like, oh yeah, that's right. I know how to be with people, but we get real reliant on these pieces. But as we think about mindset skills today versus clinical skills, we're going to give you some tools that we hope you could literally walk away and start thinking about and using. But more than anything, we hope that you see this as a lens to view people through, and that this is just how you see people as their full selves with health, and really being that person-centered first. So as we remember that you are all people today, and it is a Saturday, and I heard you say it was beautiful there. Thank you so much for spending your Saturday this way. I know that's not easy. So let's all be people first and just take a breath, take a moment. If any of you are already working, look around your space. Let yourself look away from your laptop. That may not be something you get to do all the time these days. And remembering to practice what we preach, right? That we have to use these tools for ourselves first and foremost, for sure. Okay, so we'll dive in. So as we move forward today, I wanted to start with just thinking about this comprehensive healthcare integration framework. And notice that in integrated care, they like to title things with as many words as possible. That is real. But really what this is about is that we know that people with physical health and mental health stuff together, right, co-occurring, they have these higher health needs and it costs more, and yet their actually outcomes are less. So they're accessing care more, but it hasn't been impacting their improvement to their health. And so this framework was really an improvement for how to do integrated care from the past framework. It's really whether you're integrating physical health into a mental health setting or integrating mental health into a physical health setting. This framework really works for adults and for children, population, rural, urban. It was really meant to be very flexible, knowing that particularly now, integrated care is still early in the making. That y'all, and just having watched your YouTube videos and series, like really have access to things that a lot of clinicians and places are still not a part of. The funding sources have made it difficult for people to really dive in here. And so they really came up with this integration framework to say, like, this is how you do good quality integrated care if you're following sort of these 8 measures. So the first one is screening and follow-up. So really this meant it used to be, we used to refer people somewhere and you never knew if they got there, right? It was like they might tell you the next time you see them and you didn't know if it was happening. And really moving toward formal agreements with a primary care office if you're at a mental health clinic, and having registries of people so that there is someone really following. How many people are following up with a primary care appointment? And if not, why is that? Maybe there's something we need to address, some systemic inequity there, or maybe it's they're calling and they can't get in. People don't answer the phone. Sometimes it's very practical, but really starting to identify these complex populations and addressing like who has the most need and how we are addressing that. Number 2 is really about using those evidence-based practices. So really knowing what are the risks, how to identify that, who's at risk and screen them. Before prescribing an opiate medication, maybe everybody's getting the screening to say, how much is their risk level if I'm going to prescribe this? Sometimes incentives are really tied to number 2, to using this evidence-based practice. So a provider might actually make more money if they are using a suicide screening tool like the Columbia that we'll talk about later. So there really is a push in some settings to really incentivize people to use these evidence-based practices. Number 3 is really about that longitudinal care. So, okay, we're prescribing this medication to someone. Instead of waiting 3 months to see how they're doing, are we really following up to say, hey, how'd that go? Did you pick up that prescription? How are the side effects? And really measuring whether people might be able to adhere to that medication, and really being proactive versus waiting when something's going wrong to have this early response. Number 4 is really about patient engagement, right? How am I going to promote that? Am I educating the family so they have the best way to be successful? Maybe they're using apps. Is the handout I gave them in their language, right? At their literacy level, that's going to really help them. Am I setting goals with them and really helping them be involved in their care? And so the next 4 of this comprehensive framework One is just this care team sharing information. There are folks starting to do integrated care that they have a team of people, but they're not actually communicating yet, right? So this is really about, is there an identified team? Are there huddles? Are there regular staffings to really staff folks with these complex needs? Is there really a culture of communication? It's not that, oh, the note from the therapist is in the record. It really is that people read it, and it's part of how they do care and see care, is this really care team that they have. Is the whole team going to trainings every year really about how to do integrated care? So is it really a part of how the culture there works? Number 6 metrics to monitor effectiveness of care is, simply quality improvement. Like, are there people really measuring who's getting better, or maybe more importantly, who's not getting better and why? Is there a disparity in health, and are we really addressing it? And is there really a champion or a team of people at a clinic that are like, that's our job, is to really make sure that we're targeting some metrics and really meeting them? Number 7 will look real familiar to us, but this is all about, am I referring people to these other needs that they might have? Do we truly have an agreement with the social service agencies? Maybe we're even meeting with them regularly as a clinic to make sure that we're addressing things and improving these. There are some places that now, when you make a referral for domestic violence support, it's really in a system that everybody in a community can see. So you could see, have they already had 3 referrals, to get a sense of that. So really working better together. And then number 8 is this sustainable billing. So instead of what can I do with this patient, it's more, what does this patient need, and how can we really pay for the kind of care that works? To actually clinics sort of getting payment based on doing these more integrated care practices that we know are helpful.
All right, I'm back. Can y'all hear me okay? Are we good?
Yep, hear you
Yeah.
great.
That's one of the reasons I love to have a co-presenter. So thank y'all, and I apologize. But this is something I would ask you to consider. Is there a difference between healing and curing? And because I do think the medical profession tends to be more focused on curing and fixing, and more from a more medical model, to where we may be, hey, we may be working with somebody in the last stages of cancer, and maybe our services that we're providing, the support and so forth, is actually helping them heal, but perhaps healing into death. So just kind of keeping that aware, what's the difference between healing and curing, particularly as we think about integrated care, and kind of what model do we operate from? Practice-based evidence. You've all heard of evidence-based practice, and this is something you will need to be clear on. And I believe there's even some, ethical standards related to it. It's a part of CACREP as well. But evidence-based practices clearly would be the humanistic. The relationship is probably our most powerful research-backed mode for helping folks. Also, cognitive behavioral therapy, clearly, there's research suggesting that it's very helpful for a lot of people to consider their thoughts and to consider the stories they tell themselves. I could add mindfulness-based therapy. That one's got a very strong research base. What we're talking about with practice-based evidence is for us to be working collaboratively, very closely with the client, to find out what's working for them, what's not, what kind of adjustments do we need to make, what kind of power differential issues there may be, or perceptions of such. So practice-based evidence is just being very client-focused and using what's working for them based on their values, cultural context, and so forth. I did want to, as I mentioned earlier, Katie and I just finished a class on positive psych and integrated care, and this was a Harvard study, a longitudinal study on happiness, to where over the years they were collecting data from people about their health and their wellness and so forth, and then also emotional factors and variables such as, their happiness levels and so forth. So what they found overall, the folks later in life who reported being the most happy, those were folks who did not smoke or either quit. They either we're not using alcohol or reduced it a great amount. And I know there's some controversy with that. I can talk about that, but I don't know that we have time for it. But healthy body weight, and that's something I leave kind of to the medical docs. I don't know a lot about how this relates to blood pressure and diabetes and just exercise ability, joint pain, and so forth. So I don't know a lot about that literature. Folks that were happiest exercised regularly, they had good coping skills, which I don't know that you could finish a counseling program without at least knowing about the coping skills, cognitive restructuring, relaxation, mindfulness, reframing situations, making meaning of hardships. Education, I believe they had higher levels of education in stable long-term relationships. So just to give you an idea, because I think in counseling, we can spend a lot of our time with trying to reduce illness and, maybe increase coping. And we forget that there's a side of us that's also about helping people thrive. And what are those factors that help people thrive, which I think is critical in the integrated care setting. Yeah, just briefly, the continuum of behavioral health integration. This can look like levels of integration can be. I think everybody's doing integrated care. So let's say you graduate and you've got a private practice, and I realize some of y'all will be teaching, y'all will be, out in academia, but maybe you've also got a private practice and your clients have a physician. And so there may be some coordinated effort to make sure that y'all are providing good care to the clients. I know in the medical settings, if they make a referral to a behavioral health provider, they like to get some kind of closure on that. Did the person show up? And there's a lot of ethics involved in that. But that can be that is what's going on. At the very least, you may be asking your clients about medications they're taking. When was the last time they've had a physical to find out about blood pressure, thyroid functioning, and so forth. Co-located might be that you're in a medical office complex and you see the medical professionals regularly, but you have clients kind of on a traditional therapy schedule, maybe 50-minute sessions or so forth. But there can be that, you're within that medical profession and they may call you in for consultation every once in a while. Fully integrated would be you're actually working within the practice and you are going to the exam rooms with physicians when a physician identifies somebody with depression and you're doing some assessment, maybe some brief interventions. There are models of integration as well, and targeted would be, and Katie, I don't have mine. Oh, I do. I'm sorry. I've got my notes. Bear with me. Targeted would be that we're providing treatment for high-risk client concerns, maybe diabetes, and I know at Wake Forest University, which is here in North Carolina, they've got a cancer patient support program, which is a part of the oncology department. So it's within oncology, and clients can go talk about relationship issues. They can even talk about the potential of getting wigs and so forth if they're losing their hair due to chemotherapy. And so it just provides a lot of emotional and behavioral support. Non-targeted would be that we're providing a vast array of services to folks, and this could be what you see in a family medical practice, or maybe even a federally qualified health center that's there to serve all people. And in these situations, they can get higher rates of pay and become a primary care medical home and one of the stipulations is that they're also assessing for behavioral health things such as depression, and then they get to choose. Depression could be that they do an assessment for substance abuse, could be for anxiety. And we're going to talk about some tools for that. And then reverse integration, and this is an area where Katie worked, is they actually had psychiatrists on staff within the mental health agency. When I worked in a very comprehensive agency in South Carolina. We had 3 psychiatrists on staff, 2 nurses. I worked alongside psychologists and social workers and bachelor's level social workers and so forth. It was a beautiful setting, always underfunded and understaffed, but it was a nice way that I learned a lot about medication. The docs learned a lot about therapy, And I love that kind of setting. So that would be reverse, as we've actually got, yeah, people working within our mental health agency. I'm not going to read through all of these, but just know, and I'd love to see more research in specifically integrated care. But what we do know overall in general is that it improves the satisfaction with care when there is a behavioral health professional in a medical setting. It improves access to client care. And one way this can be done is in school settings, to where you've got the behavioral health professionals working closely with the nurses and so forth to make sure that clients are getting whole person care. There was Schmidt, Watson, and Fernandez had a great study back in 2018 showing that it significantly improved the quality of life for severe and persistently mental illness, people with the SPMI versus traditional care by including the medical profession. And this just makes sense, particularly with SPMI, because we know that the medications can cause a lot of metabolic syndrome, cause a lot of different types of issues within the body. And it's very important to be able to draw blood work and see how, what are the levels and is thyroid being affected by medications? What can we do? So for me, integrated care is the way of the future. We've got, I think, 2 CACREP standards now based on integrated care. So it's the way we're moving. But I've got a couple, I think the next slides I want to talk about, yeah. This was one, and I don't think this was a publication, I got it from a presentation, is that a behavioral health intern was in a primary care office, and it wound up freeing up this amount of money just for the 1 day a week they were in there. And the way that happened is that when the primary care provider was working with somebody with depression or anxiety or addiction issues or trauma issues, that can take a lot of time. And the primary care medical providers typically only taking about 10 minutes per client. So when they could say, hey, I want you to see our behavioral health intern that's on staff, then that person could spend a lot of time with that person. This way, the primary care provider could bill more. They could see more clients and bill more. So by having an intern, it actually allowed the practice, first of all, to give clients better care, but then also to free up the provider so they could bill more. And that turns out that wound up to be about 58,000 a year, which is not a bad salary for a behavioral health provider. Of course, we want it higher, but not a bad starting salary. One other thing, just to kind of emphasize the importance, I think, of integrated care, this was shared to me by one of our students and now graduates, is that his father had a heart attack. And then when he was in college, the student, he started having chest pains. And so naturally, as it should happen, go to the ER, get tested, do all that, especially with a family history. What he did say is after all these different tests on several different occasions, nobody ever asked him about anxiety. And that's what it wound up being, is his heart was perfectly fine. The vessels and the arteries were clear, but he was experiencing anxiety. And had there been a behavioral health professional who could have said, we may have still done some of these initial tests, but it'd have been nice to have done like a generalized anxiety disorder 7 screening just to see. And then we can start giving him the actual care that he needed. And so just another reason I think integrated care is so important. And I love this, this kind of revision of the Hippocratic Oath. And so this is what doctors, attest to, is that there's art to medicine, that we need to be flexible and we need to understand that science is wonderful and there's also art. And this is where I think we come in with just the human relationship and how do we be creative with clients. I love this slide. This is from a French study back in 2003. And I want y'all to consider this too. I've asked y'all to think about, hey, what's the difference between healing and curing? But also, I believe that as counselors, we are specialized healthcare providers. And so maybe throughout the rest of today for you, and I know you've got a long day ahead of you here, but is to think about, well, how do I actually explain that to folks? Because here's a study with somebody with a phobia of spiders, and you're seeing that lit up with that fear response in the prefrontal cortex. But after just a few treatments, I think it was 6 treatments of cognitive behavioral therapy, they can be exposed to the spider and not have near as much activity. So, in that regard, the cognitive behavioral therapy is actually causing neurological changes. We are strengthening neural circuits to where they don't experience as much fear. Now, I don't know what's going on in the back of the brain. I do see the yellows lit up there, but perhaps that has something to do with some coping as well. I think a lot of visuals back there. Um, and then another study that I wanted to say, this was in Germany, and they found that it was pretty cool. It was a big sample, 22,000 folks. This is on my YouTube channel, by the way. It's how psychotherapy reduces healthcare costs. And they monitored the records of 22,000 clients prior to receiving psychotherapy. And then they monitored them after receiving psychotherapy a year later after psychotherapy. And what they found is that it was significantly less work disability, significantly less hospitalizations, which are very expensive, and less medical cost overall. So I want us to think about this idea that as counselors, we're actually specialized healthcare providers in the same line as dermatology and cardiology and psychiatry, that we are providing services that are actually affecting the body and can reduce costs. And everybody wants to hear that. If you're wanting to advocate for integrated care, talk about how counseling reduces cost. And Nadine Burke, this is not a picture of Nadine Burke, but I love this picture. But Nadine worked in Oakland, California, and I believe at one point she was the Surgeon General in California. But I love this, is, she said, hey, a treatment protocol that I would like to see, and she's working with young folks, is that they receive some biofeedback so they learn how to kind of regulate stress, as well as person-centered therapy so they feel supported and they've got a safe, confidential space to be able to kind of talk about their issues and learn coping skills. I expect that we're going to hear a lot more from medical doctors about this. I know a video that I particularly like is they were showing the primary care medical doctors are considered the social workers of the medical profession, because that's kind of the entry level where people go in to get kind of primary care. And I know that one of the docs was talking about how when he was studying to become a primary care medical provider, they said, hey, about 80% of your clients are going to have mental health issues. He said after about a year of working there, he said it's 100%. And I love this kind of notion that medical docs are, first of all, probably starting to become better counselors, but also starting to recognize the value of counseling to help their patients, and at a very physical level. And one thing to keep in mind, because I got in trouble, I was talking with one of our social work faculty, and she's like, "All your students are just wanting to do this long-term therapy and stuff." And I will say that working in integrated care, those of y'all that have any school counseling background, y'all would be very well trained, because integrated care is, you've got to work well with the doctors, with the administration, with the medical record folks, with the legal folks, as well as the clients, as well as their kids, and maybe even their parents. And that's the same thing about school counseling. So I know when Eric Christian and I created the edited textbook for integrated care back in 2012, he actually came from a school counseling background. And he said that was perfect training. And so if you'll think about what school counselors do, they have brief treatment with students, but they're also kind of working with the administration and teachers. That's what you're going to be doing as well in integrated care. So you need to be a generalist. Okay, I've got my notes here. Just work with a lot of issues, depression, anxiety. later talk about COPD, sleep issues, irritable bowel disorder. There's a lot of different things that you don't have to be an expert in all of them, but just kind of have knowledge of how you're going to work with this. You need to be accessible. You can't just be like, nope, I've got my client. I'm going to be sitting for 50 minutes in my office. This is a lot more fluid type of operation in integrated care. So I might have 15 minutes with a client. I may be doing that within the exam room, and then I'm going to be available when the doc has another consult. Very team-based, appropriately collaborating with the team, which I emphasized earlier. High volume, so you're seeing a lot of folks. It's not just 50-minute sessions. Using good psychoeducation with folks. And then also, you're just a part of the practice. That's the routine piece, is that I remember talking with somebody that worked with Katie in an integrated care setting. And at first he said, yeah, the docs aren't referring a lot of people, and it's kind of hard to get clients. I saw him a year later and he goes, oh, I'm just packed. I'm busy all the time. And I asked what the difference was. And he said, I spent some time really getting to know the medical professionals I was working with, the front office folks, and so forth, build relationships so that they trusted him, and then started making more referrals. So.
We wanted to just give you a couple examples of what integrated care can look like. In a perfect world, it would look like there was a clinician in every primary care practice, several of them. But often it looks different. It might just depend on where you're from and what grant funding or funding's available. But in one place I worked, it was a mental health substance use clinic. And we were able to get a grant that added a primary care doc to the mental health clinic, as well as a peer support specialist. And this was a really cool model. The peer really became part of the appointment. That peer support had lived experience with mental health and health conditions. She had had chronic pain, she had diabetes, she had struggled with depression. And so when appropriate, she could really share her story about what it was like, and really had lived experience about what it's like to try to interact with medical care and a lot of the barriers that came up for her, and stigma, and some of the difficulties. So she really had that firsthand knowledge, and she would meet with people, really get to know them, their strengths, what was getting in their way. And they would talk way more to her than they would to the rest of the team. And then she would really be able to focus on that relationship and focus on where was this person in stage of change. Were they ready to make some changes, or was she just helping them get engaged until maybe they were at a different spot? She did a lot of phone support. She took so many people to the grocery store. And so many of those folks just hadn't had the experience of shopping on the outside of the grocery store. Like they hadn't had a life resume of being able to put meals together or make different choices, and to do that within the context of a relationship. And we saw the follow-up appointments like really skyrocket. And people would always come in, and she was available and the primary care doc was, and they could really work as a team.
Now, I like to stay in the inside aisles where I can get Cheetos and chips and Coke, Diet Coke, and all that stuff. So I need to learn to work on the outside of this grocery store where the yucky vegetables are. Is that what you're okay?
You got it. That's exactly it, right?
All right.
And in all honesty, I did not know what several vegetables were until this peer support taught me. We were like, what is that, right? But just to have that person that they trusted made a big difference. So in another integrated care practice, we really addressed one population. And this was a really interesting, it was in a huge rural area. They had done research about how many of their patients in this primary care clinic had substance use, and it was like less than 1%. Which, if we know anything about substance use, that's not possible. That would be a miracle. But it was just because people didn't feel comfortable sharing. And just by adding this clinician who also said, yeah, I work with people that struggle with addictions, in that year, the people's report just went up. It wasn't even a screening tool. It was just like what they were flagging. Just by offering behavioral health care really decreases stigma. And what they did here was they really did know that there had been a long-standing practice at this rural clinic where there was a lot of people taking both opioids and benzodiazepines together, which together can kill you, right? Just people go to sleep and they don't wake up, suppresses your breathing. So it could be really dangerous. So at that practice, they literally just ran a report of everybody that was on both of these and really worked with a provider, the provider, who really decided, like, is this appropriate? If not, really, what's the plan? And for some people, that meant doing a very long taper. For other people, it meant really offering them even a referral to come off the medication in a residential setting. So not easy at all for the patients. Some of them were elderly, and all of a sudden someone told them, hey, this thing that you're doing, we're worried about it. And it was shocking and really hard for a lot of people. So they introduced the counselor who could really offer this individual support, do phone call check-ins with this group of people, and they had a support group of people who were being tapered off some of these medications that were so difficult, and also really looking for dangers and risk as a team at the primary care clinic.
And Katie, as you're switching slides, just with the long taper, particularly for folks who've been on benzodiazepines a long time, that's just that, okay, you're taking 1 milligram. Now we're going to go for a week with a 0.5 milligram, and then maybe 2 weeks on that, and then another week on a quarter, because coming off of benzodiazepines in particular, suddenly or cold turkey can lead to seizures and death. So just a little bit of medication stuff. When you hear that term long taper, that really needs to be monitored closely. I had an incident when I was working in mental health where somebody quit cold turkey and did have a seizure. Fortunately, I was in an integrated care setting because we had medical professionals that could help and support this person, and he was fine. But it was very scary to everybody involved. Yeah.
Yeah. Yeah, thanks, Russ. And the reality of that was not a pretty process. And the providers were really clear. A lot of them were new at this clinic, and they took over these patients that were on high amounts of benzos and opiates. And they would say, like, I'd been wanting to taper, but I didn't have any support. And I knew this person was going to have a big moment, go into crisis, maybe make threats because they're really in this place of not doing well. And it was this moment for me, you're like, oh, these are just human beings, these doctors, right? They're just human beings that don't even have some of the skills and tools we have to have these kind of hard conversations with people. And they really felt like they could do that with the presence of this counselor who could be a support. And that first couple weeks of people getting the information, that counselor got support from me and another counselor, because often the first appointment, that patient would be like, so can you get me my regular prescription back? I really need this dose. Or it had to be sort of this session where they realized, like, oh, I can't prescribe anything, but I'm here with you. I get it. I believe this is hard. I'm not going anywhere. We're going to work through this together. And then you may be wondering why there's a bunch of M&Ms on the page. I'll tell you about that. But in integrated care, I think we did this experiment where we added a clinician to 5 primary care clinics. And we had this idea that we would all have this same journey where it would turn into these integrated care settings. And they were all so very different. As Russ described, one of them, like, all of a sudden it was hard to get relationship with the providers at first. But so they would send anybody in crisis, anybody yelling, anybody taking up a lot of their time. Like, that's how it started. But they saw this behavioral health clinician, his name was Garrett, who, like, could handle those. And over time, they built trust and gave him more and more people. And another behavioral health clinic, they had a lot of children who were looking, and their schools were looking at whether they had some ADHD, and they were really able to target that population and screen for trauma along with doing the ADHD screening, and really set up a protocol to do this and do this well. And in this particular clinic, I'm going to tell you about right here, it was taking a lot of time to build relationship with the providers. And this particular clinician was creative. She was patient. In the beginning, she had days without very many people on her schedule. That changed. But what she started doing is they had these huddles where the providers would talk with the nurses about who was on their schedule. And she would join these huddles, and she would bring M&Ms. And she literally would say, like, is there a behavioral health component to that client? And she would give the providers M&Ms. And they thought it was funny, but they started saying, oh, this guy's got a little anxiety, or, oh yeah, this person is going through a divorce. And it was like they all had a behavioral health component, right? But over time, she really built relationship. And my experience has been, when providers start asking you about their personal lives, you're like, I'm in. They're like, hey, my daughter. And you're both like, oh, let me pay attention to boundaries. And you're like, they trust me. They're now asking me these questions about their lives. But it does take time to build some relationship for sure.
Do they make blue M&Ms? That didn't, I don't remember that. Yeah. All right. Just a reminder, just for your kind of working with folks, is that in integrated care, you're going to use the essence of counseling school with everyone in the practice. So the good person-centered skills, existential, even cognitive behavioral solution focus, that you're building relationship with everybody in the practice. And that's going to make it, just as I had mentioned before, make it to where people trust you, they get to know you, they're going to want to refer clients, they're going to want to consult with you. I'm a little bit woo-woo, so I like to think of what vibration am I bringing to this practice? You could say what mood, what energy. And I think it is kind of higher order cognition to be looking for what's going well and then being able to talk about that in the staff meetings. And that also is a way to kind of start building rapport. Listen a lot because people want to know that they've been heard, that you can kind of balance the situation. So this isn't like a lot of times when we get insecure, we're going to want to share information. I would say kind of sit with that, be aware of it, that that is a natural tendency, and say, no, wait a minute. I want to listen. I want to listen to understand and use my good reflection skills so that people feel heard. We're going to build rapport, keenly assess personality and the most effective communication strategies. Going to talk about this a little bit later with the medical docs, and then work to see the strength in every person, every situation. Again, that's kind of a higher order cognitive process to do that. And it's very easy to try and just go back and recognize what's wrong. And we'll be able to find that everywhere, the things that we want to improve. But to be able to see what's right, be able to communicate it, that's going to be really effective for you, really in any workplace, but particularly integrated care.
Yeah, and this is just this reminder of that we're always doing integrated care, that we're always trying to see people through this whole person curiosity. Um, Whether that means we're asking everybody, like, tell me about your health. Tell me about your health conditions. What medications are you taking? What does health mean to you? I was thinking about a newer client that I have. I asked, like, when's the last time that you've been to the primary care doctor? And he told me, oh, it's just a couple years ago. And when I asked a few more follow-up questions, it had been like 11 years since he had been to a primary care provider. But in his mind, right, it was just a few years ago. So sometimes people aren't asked these things like we think they are. And we can get curious about, like, oh, it's been 11 years. Does that seem like a long time to you? And asking people to just get some support. Let's just get a good physical. Let's just see, like, make sure that things are doing all right now, right? And really identifying that and making sure that another woman comes to mind that I saw in integrated care when we think about what is getting in the way of their progress. She was a grandmother caring for her daughter's 4 children, so she was very busy. And she often only wanted to go to the pharmacy through the drive-through. And Russ, if you've ever been to the CVS pharmacy on Patton Avenue, there is a drive-through, and it looks like every car has hit it. And it would make her so nervous to try to make this turn. Like, you had to be an expert driver to make the turn to get to the window, that she
Yeah.
just wouldn't go, right? And she was so busy and so much on her plate that it just didn't occur to her, like, we could use a different pharmacy and to pick a pharmacy based on a drive-through, right? So sometimes just being curious about people's experience and asking a few follow-up questions. Are you taking your medications is not a great question. It might be the first question, but you might want to ask, how many are you taking? And you'll find out pretty quickly that people aren't taking them. Or, man, I know it's hard for me to remember sometimes. How do you remember to take your medication? And people will be like, oh, I probably take it half the time. And they'll start to be real honest when we can be very curious and let them know that this is all of us, right? This is all of us working on our health.
Thanks, Katie. Yeah, this was the slide I was talking about, and I do want you to be aware I've got this from Chat GTP 3.5, at least the left-hand column, is using the 5-factor model, which is, a theory of personality based on language, not theory, such as the Myers-Briggs type indicator or Enneagram. Those are based on theory. This is based on language. That they were kind of compiling different study results and finding that medical doctors, and of course that's a huge group of people, tend to be moderate to high in openness, conscientiousness high. They have to be. They could get sued for writing down the wrong medication or so forth. Extroversion kind of varies a little bit like it is in the mental health world. We have extroverts and introverts. Agreeableness high and neuroticism low. And that's one that I kind of wanted to make stand out is that it's possible. Everybody's different, of course. It's possible that if you were to take 100 medical providers, that they don't experience the same levels of anxiety, depression, and feel for folks the way we do. They're obviously caring. They wouldn't be in that field. But so what I did on this on the right hand side, or at least right facing, I was asking folks, including Katie, about all right, what's been your experience? What personality characteristics have you noticed from medical providers? And that they're driven, typically academically gifted. That comes with strengths and challenges. Sometimes that can reduce their humility at times because they haven't had to question themselves. They got a lot of boost for being great in math and science or whatever it may have been. But they definitely want to help others. They're independent thinkers, problem solvers. And that comes back to the healing and curing a little bit. It's like, well, I want to solve this. They got anxiety. Let's solve it. We can solve it with, a SSRI. And we know that's not so simple. They like to learn. I think we're all kind of hardwired to learn, but specifically, definitely docs are really hardwired to learn, and they are empathetic. The primary care physicians I have throughout my life have been very empathetic people by and large, and so it's helpful to kind of understand just we're dealing with people, and we need to build relationship with these medical providers equally as much as we need to do with the clients we're working with. And that helps build trust. So, some specific language to use. Now, this is another thing. When I was talking with one of our social work professors, like your students are just using all this language that's going to freak the medical doctors out. Space and presence and person-centered and all that. We all know that. But here's some language that we can use with medical providers. Hello, doctor. I'm using motivational interviewing right now with so-and-so to build rapport and to increase their motivation. I'm using 15-minute kind of prescriptive, maybe even solution focused, which we're going to talk about more, types of therapy to be very direct about what they're experiencing and help them figure out coping. I'm assessing using the patient health questionnaire 9, the generalized anxiety disorder 7, but all of those are in the public domain, by the way, and have good reliability and validity, but they're brief, so we can talk about it with clients. And also trauma screen. Maybe I'm using the ACE test or others. We've got a whole slide on the 5 A's of smoking cessation. That's also one of the videos that Katie created for us on my YouTube channel, so you can see how that's kind of done. The 6 A's of opioid, and I am going to need to, I forget what some of these are. Just, hey, doc, I'm using the 6 A's of opioid use reduction to help reduce their opioid needs. And what that means for me is that I'm asking about their pain level and how that inhibits normal activities. I'm asking about their level of pain on the scale of 1 to 10 and the effectiveness of the medications. I'm asking about side effects of medications. Are there any drug-seeking behaviors? Do they ever get opioids from other sources than their doctor? How's their mood? How's their affect? And other things they may experience, such as anxiety and depression. And last but not least, documenting really well, particularly when clients are on opioids or benzodiazepines. And sometimes they're signing a client medication agreement saying that if their medication is lost, it will not be refilled by that provider. If they call to ask for increases, they're going to need to come in and get blood work and so forth to test. They may have to do urine screens each year in order to still qualify to receive these medications. So that's not an uncommon thing, is to have that kind of that document at the end for folks on these medications. And it's just a way to, help also protect kind of the liability of the medical provider, that they're doing everything possible to treat the client, but also monitor that they're not abusing substances. And one thing I'm having fun with my classes is using AI to assess personality. And I have not said this to a doctor, but I think it's something that it may pique their interest a bit, is that, of course, you're not entering a client's name, okay? But being able to take personality variables and maybe scores on a PHQ-9 or GAD-7, again, anonymously, and saying, hey, chat or Meta or whatever, what might be a treatment plan for somebody who's got these characteristics, who identifies as this gender, sexual orientation, race, ethnicity, spiritual or not spiritual? So you can enter all of that. And my students are having fun, and I'm impressed with what I'm seeing from chat and Meta on kind of the treatment plans that get created based on this preliminary data. Docs, medical professionals love algorithms, and they love when it's kind of sciencey. So when you can say, hey, this was the thing I got based on their personality variables and how they identify, that may give you a little bit of buy-in. It's really quick and easy to do. Again, ethics are involved. We're not going to use client names, but yeah.
And for those of you looking for jobs in the coming years, like using these same personality traits to put into AI for your own self as you think about interviews and what makes you a good fit and how to talk about that, it can be a great tool as well. Russ, it is right at noon on the
Yeah.
dot.
Why don't we take 5 minutes to stand up, not stare at a screen, and then we're going to start talking at 12:05, whether you're here or not, just because I know we're recording. But how about we do that right quick? Yeah. Katie, it looks like we're making pretty good progress in terms of, yeah. So I think just staying at this pace and we'll be good.
That sounds great.
Okay. Anything else that you would add?
No, need anything from me?
No, other than thank you for my computer glitch. I've got some serious problems with the computer, so thank you.
Yeah, no worries. I gotcha.
I'm gonna go freshen my tea and I'll be right back.
Okay, sounds great.
All right. All right, let's see what we got next. Y'all doing anything fun this afternoon?
We are. We're gonna we have some friends going to hang out at the park, like bring in lawn games and it's beautiful
It is beautiful.
and 20 degrees cooler than the for the rest of y'all there. Not to brag.
All right. Okay, we're 12:05, so I'm going to keep on going here. Thank you for that brief break, and I think we're on a good pace. I just wanted to talk about the spirit of the initial client meeting, and it's to be curious. And I think being curious and interested in the person. The reason I think that's healing to do that. And the reason I'm specifically wanted to keep the slide in the integrated care presentation is you can feel in a medical setting a bit like a number. And because these docs, the medical folks feel a lot of pressure to see all the different clients that are in the waiting room. They know that they're uncomfortable or sick or hurting, and the client can wind up not being seen. So I just want to emphasize that that's one of the healing pieces of having a counselor within the medical profession is to truly see clients and be interested and curious about them. And I do believe from an energetic standpoint that that is healing, that at least surrounds them with that good loving energy, if you will, that lets them know that they're worth something. And they may not always feel like that in a lot of medical profession offices.
Yeah, thanks, Russ. And I really believe this next slide is a tool to do that. Like, this is how we let a client know that they have been seen. This is one way we can do that. So we call this in our field, right, case conceptualization, right? I feel like we should rename this, Russ, in some way. But to me, this is really, how do I let this client know I kind of, the best I can, I get the story that they're sharing, right? And the reality of integrated care is there's not a lot of time to do that directly to the client. And there's not a lot of time to do that with the providers, that we can't drone on and be all over the place in our description of someone. So I think this skill of conceptualizing and being able to do it quickly, but honoring the client is really important. And so I know there's a lot on this slide, but I encourage you to like take this with you. But this is really about being able to say, like, it makes sense to me why this is happening for you. Like, given what you've been through or your family history, what's happened in your nervous system, I get that. And to say, and what's most important right now, based on what they've shared, that's the why now. Like this, so it sounds like you starting to feel better and be able to move around more. That's what's most important to you right now. Did I get that right? And to check in with them. Um, then to be able to say, this is what's made this health problem hard, or here's what the real barriers are. This can really take away the shame and the blame when we can name those, whether they're systemic or personal, to say, like, it makes sense. This is good. There's some hard things as we try to make progress in your health. And then most important are those protective factors where we can communicate with some confidence. This is why I'm really hopeful for you, that you can make progress or that you can work on your goal, that you can get better, right? And being able to say back to the client their strengths, what they have going for them. And so if we can do these four things and do it in a real human way, but also concisely to the person, I really believe this can be like one of the biggest gifts we can give a client in one of those first sessions of meeting. I see why you're here. I see how you got here. I hear what's most important to you. I see what's in your way. And I believe that we can do some good work together.
And just keeping in mind, I think if we're doing open-minded treatment plans here, it's the client is always first and the problem is second. Treatment plans really come from kind of a medical model standpoint. There's something wrong with you. We're going to fix you. We're going to treat you. I really do believe healing is more of a collaborative effort. And this is why I like integrated care, because we're going to collaborate. We're going to get behavioral health professionals working together with the medical professions. But just from a philosophical standpoint, keep in mind that this is client first, problem second. And as much as possible, this is definitely a trend in mental health, is that it should be a collaborative treatment plan. And even the notes that you're taking should be collaborative. Okay, so help me out. We're billing third-party payer here, Medicaid, Blue Cross Blue Shield. I need to create a note on what happened today. Tell me what was most significant for you that we talked about today. So that might be an example of how you start a collaborative note. And I know Katie has also got some videos on my channel about collaborative treatment plans and how to do a very collaborative intake. You're typically not going to be doing kind of the drawn out intake in an integrated care setting, but she does a nice person-centered intake if you want to check that out. Okay. This was a great video, and oh yeah, it's a part of y'all's. Yeah, this was awesome. So I would highly recommend watching this or rewatching it if you haven't. Clearly, BIPOC considerations in all of counseling in the world are critically important. It's a lifelong process for me, particularly as an older white male person of privilege, to be continuing assessing my biases, self-reflection. But there's some really cool kind of concrete questions that can be asked, particularly from the cultural formulation interview and I've bolded those here. Are there any aspects of your background or identity that make a difference to your problem? And have you felt misunderstood by healthcare providers? If so, is there anything that we can do to provide you with the care that you need? So just always being very sensitive, very humble about assessing this and continuously self-assessing who we are and how we see the world.
This image that you see here comes from George Washington University from the Building Community Resilience Coalition. But it's really looking at how does the systemic interact with the personal. And if we think about this image with this tree and these roots into the soil, what we often see is the leaves, right? This is what comes to us. This is how people describe us and the people that we serve. Oh, there's a lot of mental illness, or dad's incarcerated. There's domestic violence, there's addiction, right? And we often get really focused on these leaves. But what we want to really pay attention to in our work as we advocate and are part of these bigger systems is like, what soil is this tree trying to grow in, right? And that we use the words, right, social determinants of health, but simply like where we play, where we love, where we work, where we worship, where we live has huge impacts on our health. And often we want to recognize that this is what's contributing to what's happening. So we also don't get part of the systematic problem of blaming individuals or groups of people when it really is this soil that's impacting people in their lives. And then we think about how is it impacting individuals and groups of people. I know there's a lot of organs on this slide. I'm not an expert in any of these just because I've worked in integrated care. But if you look at the left side, that's really a picture of just our break, right? This rest and digest, when my body can relax, when things can be okay. And then on the right side, the gas pedal is our sympathetic nervous system, but this is stress. This is fight and flight, right? And so when someone is living with these inequities or this stressfulness or these personal traumas, their stress response might always be on. And the impact of that in a real physical way, as Nadine Burke, who we mentioned earlier, talks about, happens, right? It's what we know about the adverse childhood events study, but that later in life, I really do have diabetes or COPD because I've had stress hormones raging throughout my system for so long, that my blood sugar levels really were increased for so long that it's impacting my health, or that it was so overwhelming, that stress response, that my brake pedal has been stuck for too long. And there's not enough happening in my body and biologically that it really is impacting my health. I know one of the biases I recognized is years ago, I recognized like, oh, anytime I see somebody with oxygen in my mind, oh, they must have been a smoker, right? And we know that that's not true. This might have been a person who had all of these personal and systemic traumas, and their nervous system has this response. And this is where I just believe in integrated care. We can be these huge healers that, one, understand that, and it can take the shame away from individual or groups of people that have been blamed and shamed. But also we can build health by helping people turn off their stress response, right? These relaxation, mindfulness, all the tools that you guys know and are learning is what can help people really be empowered. Like, I can do something about my health that improves health over time.
Okay, I do recognize we've got about 30 slides left in 45 minutes, so I'm going to go pretty quickly. But what I want to say is the Patient Health Questionnaire 9 would be one of these tools. I would want to create a folder on my desktop and say, okay, here's a public domain tool for measuring depression. You Google it right now, you'll find all different kinds of versions, including online. But this is a nice way to measure for perhaps depressive symptoms. I like it because it's brief. Now, it is I think most people would say it's a reliable and valid tool, and it's got good psychometric properties. But what I like about this tool is you can discuss each question with the client. They're asking them, have they experienced these over the last 2 weeks? And if somebody says, well, I've had little or little interest or pleasure in doing things more than half the days, then that can actually be a conversation that we have. And then I can also clarify, did they understand the question? And are there other things that we can be looking at? So the Patient Health Questionnaire 9 would be one I would want to have in my toolbox before my first day of working in an integrated care setting. Again, the medical profession loves their algorithms. When you see them looking at their PC or their pad, they're usually like, all right, this person's got this blood pressure, this thyroid condition, and typically algorithms come up saying, all right, consider this, do this. And the same thing here with the PHQ-9. It's just talking about severity and then what might be needed. I don't know that we need to say more about this slide. Just be aware that these exist for the total score. I still like the aspect that I can discuss each question with the client. Another tool I would want to have in my toolbox before the very first day would be the generalized anxiety disorder. Again, this is from Pfizer as well, and asking for over the last 2 weeks, have you felt nervous, anxious, or on edge? And just on the same scaling as the PHQ-9. So a nice way to determine if maybe people are experiencing anxiety. Now, that's the #1 mental health issue in the world today. It's surpassed depression, as far as I'm aware. So this is one that, as behavioral health professionals, we need to get really good at treating and working with folks with depression and anxiety. And this is another public domain tool you can use. So what they've done here is combined the first two questions of the PHQ-9 with the GAD-7. And call it the PHQ-4 for whatever reason. But this can be a nice kind of brief way of kind of at least starting to get some understanding if somebody's experiencing this, and do we need to assess further? I think if they were to indicate having several days on any of these questions, then we could bring out the PHQ-9 or the GAD-7 to have further discussion to see. And might this person benefit from some psychotherapy, but possibly also some type of medication that may also help?
And there's something about having these screenings, right? I think sometimes as counselors, we're like, oh, I'm using paper. And but it actually, for the patients, will say like that felt safe to them. Oh, this is something this practice must do. This must be a safe topic here. Like, this is what you guys do. It can really take the stigma out of some of this.
Yeah.
So in thinking about addictions, this one is particular to alcohol. This is the CAGE screening that really guides you, and just asking a few questions. You'll see them here that you can ask everybody and pretty quickly. And I think the most important thing is like to get comfortable asking. So it sounds conversational so that you can do it and it's pretty easy coming off your tongue, and to say things like, how much or how often, or hey, some clients tell me ... How's that been for you? So that they know that this is something you do, that this doesn't have to be the one health issue that everybody sees as having so much stigma, that this is just part of what you do as an integrated care clinician in that practice. Same things for treating tobacco. I know many of us will spend a lot of time learning about all types of substances and how to support people, and that is important. And most people will die not from those substances, but from tobacco use and health-related issues from that tobacco. And the 5As is really a model that's shown, used over time, that using almost every time someone comes in, that really does help people move through the stages of change to address their tobacco use. So you see the questions here and some strategies. But I think most important for us to know is that most people want to stop using tobacco, and most people have tried to quit, right? So half the battle's gone there. Not that it's not hard, but that's why we want to keep addressing it with people. And I know it's kind of weird to see that second one, advised to quit in a clear, strong, and personalized manner. This study was done with providers, and I think there must be something about like a doctor with expertise saying like, in a personalized manner, and they could probably use some suggestions, right? To say like, I know you really care about this, and maybe one of the best ways would be to stop using tobacco. So I just urge you to use your counseling skills when you see that second A. And then when we're thinking about a screening and assessing for risks, I know for most of us, the first thing we think about is suicide risk, but we also want to remind there's lots of things that can make people at risk for something. And sometimes it's risky behavior, driving too fast, just things that might come up. And so that first one, assessing what is said or unsaid, we're always looking for risk. We're always looking for, wow, this is new, or I just flagged this information. And then these are just sort of the areas of risk that we want to get good at paying attention to. Yes, there are risk factors, which are things that make us at risk forever. If I have a family member who has died by suicide forever, I have a risk factor, right? Versus warning signs. So things that show me, man, I really need to lean in and pay attention. This person like wants to crawl their skin and is not sleeping and has had some thoughts of suicide. So really thinking about the difference between those. What is the patient's response? So if I say to Russ, like, wow, it sounds like you've really been thinking about harming yourself. Like, what's that like for you to hear me say that? And he's like, that's no big deal. Like, that's information, right? Are they joining us to look at their risk together and they're concerned, or are they really tuned out or checked out? Really paying attention to protective factors. What is it that keeps you alive? How come you haven't tried to harm yourself yet? You know, what do you really turn to on a dark night? Looking for those protective factors. And what we're doing often is just weighing those. It's like a scale, that there is some risk factors and this person's faith is a huge support to them. And we're always weighing those out. Thinking about the difference between a safety plan and a coping plan. So a safety plan is often like, if I'm feeling like harming myself, I will do this. I will call this person, versus a coping plan. Like, how am I just on a regular day-to-day? What tools and supports and things are going to support me, or what gives me joy or meaning, and how am I building those in my life? Always thinking if there's any risk, who else in that family can you connect, or friends, pull them in, get a release, let them know, like, no one should have to do this alone. How do you feel about us calling your sister and let her know what's going on? I'll help you with it, right? But really pulling in other people. And then the same thing, who are you including for your support? When we're holding risk of someone else, we also need support, consultation. Consultation isn't there for when we don't know what to do. It's also there to support us as we just do this hard work. So when we think specific about suicide risk, this statistic always sits with me that 64% of people who attempt suicide visit their doctor during the month before their attempt, right? So when we think about integrated care setting, this is really crucial. And a lot of people that do die by suicide, they are not connected with mental health services. They're much more likely to be connected to a primary care or other health-related service. I wanted to put the Columbia in here. You can go find this online. Just Google Columbia suicide scale, because it has some great questions. And if you can get really familiar with these questions, you can get comfortable when we're assessing risk and being your conversational, genuine self that can put the other person at ease, because it does impact us to have these conversations. And this is a great resource for you to start looking at, oh, here's a couple ways I can ask this question about risk. And then what we know is that if we can reduce the access to means, so that can be firearms, that can be Tylenol, which can be deadly, right? The greater distance we can put between that person and the thing that could kill them can save lives. So that can be as simple as if you have teenagers, you keep a little bit of Tylenol out in the medicine cabinet and the big bottle is somewhere where they don't know. It can be really supporting someone. Hey, I know that guns are important to your family and your culture. We're not trying to intrude there, but I wonder if your brother could hang on to this until you're feeling better. And here's just some wording as we get used to doing that. I always recommend to anyone, there is something called the CALM training. And it really is a training to support us in learning how to talk to somebody about reducing lethal means, as they call it. So check that out. It is free online that you can do.
I know one thing with the previous slide that made an impact on me. Katie's from St. Louis, and I'm from Charlotte, North Carolina. So I was raised in a culture. My granddad had me shooting guns at 8 years old and kind of safely using that. And Katie was talking about how typically ownership, at least when she was younger in St. Louis, was more associated with malfeasance, where it wasn't for me. And so being able to talk kind of balanced in a balanced way with folks, like, hey, this may be a part of your heritage, who you are. We just want to make sure that when you're feeling bad, you don't have quick access to something that you would regret, and later. One thing that is not talked about, and we are going to be getting into a little bit more of some of the specifics, that as behavioral health professionals in integrated care, we need to have a general understanding of irritable bowel disease would be one of them. And there are more severe, ulcerative colitis would be more severe, but it fits within the umbrella of irritable bowel. Crohn's disease would be even more severe than that. I definitely wanted to highlight there can be many different, the etiology or what's causing irritable bowel. There can be many different routes for that, but one that we may forget and the medical profession may forget is that the silent chemicals, the PFASs, that they're still not 100% sure what is the safe level. It's in all of our waters. It's probably coating our carpets, some of our clothing, even in makeup. Has been associated with those as well as other cancers. So there's been lawsuits won showing, but irritable bowel disease is one of those that has been related to the silent chemicals. I want to mention that because you may be working with a client and you're thinking, oh, this is all stress related. It very well could be stuff they're ingesting that's actually causing this to be harmful. However, there is some research suggesting that if we can help people with IBD manage their stress well, it does reduce symptoms. So be aware of this and just know that when folks are experiencing IBD, as it well could be one of you, first of all, this is not something people talk about. I think we're actually a little bit more open about talking about depression and anxiety, maybe even addiction a little bit more freely than we do IBD. And it's related to pain, just kind of constant pain, bloating, diarrhea, fatigue, unintended weight loss, and it affects every aspect of somebody's life. Issues with relationships, employment. Oh, I can't work in this setting because I've got to have access to the bathroom, and this would be have me out on a construction site or whatever. The nutrition, are they really absorbing nutritions if they're having such issues with the gut? So this is one that I would say, hey, if you got a presentation coming up, this is one I don't hear talked about enough in the mental health world. And that might be one you want to focus on. Because I think it's more, I don't know what the prevalence rate is, but I suspect it's going to be more prevalent than we know, that people don't talk about it. I'm going to pause for a second so you can screenshot this. It's such a beautiful photo. And I want you to check out this scarf. Check that scarf is dope. And yes, you're welcome. You're welcome, y'all. I wanted to give you something really brief. Have y'all screenshotted? I don't want to talk while you're okay. Okay. Um, I want to give y'all something really specific of how you can create really brief interventions in an integrated care setting, and kind of came up with this acronym of Dr. Help. This picture is making me laugh. Sorry. Is first we're going to discuss the issue. What are you experiencing? It's nice to meet you. And what are you experiencing? A lot of times in a quick environment, that's all we're getting. We might be in the exam room with somebody. Then ask them to rate that, hey, on a scale of 1 to 10, how problematic it is. And we're doing that so that oftentimes when we're feeling issues, we're very in kind of the emotion focused area of the brain. By asking them to rate, we're going to start activating more of the logic area of the brain so that we can have a little bit more integration. So we're going to want them to move into some numbers like, oh, on a scale of 1 to 10, it's an 8. What has helped you feel better? What have you tried? This is something I think the medical profession doesn't do enough of. We want to ask people, well, okay, I tried this medicine. I tried this over the counter. CBD didn't seem to work. So let's ask people what they've tried. It honors their experience and their story. Explore exceptions to the issues. Okay, you're talking about experiencing a pretty extreme amount of anxiety. Are there any exceptions when you're not feeling that? Because we want to really explore that. Oh, wow. When you've adopted an attitude that you don't care what people think about you, you're feeling less anxiety, whatever it might be. We want to really look closely at that. That may give us a doorway into some coping or treatment issues. Perhaps, if possible, talk about life chapters. Hey, it sounds like this has been a really tough chapter for you with trauma or anxiety, stress. Hey, can you help me start to begin what chapter two, a better chapter two would look like for you? So we're using different modalities when we do this. We're using solution focus, we're using narrative therapy, we're using motivational interview and person-centered. Even acceptance and commitment therapy, particularly with the life chapters, because we're saying, hey, we know that you're more than the issues you're experiencing. And I'm wondering can we just initiate some conversation about what you'd like to see in a chapter two? And then asking also, this is a very solution focused, is past successes with similar problems. They may not be able to come up with it, but what we're wanting to do, if you think about this from a neurological standpoint, when we're experiencing issues, we are involved in that, and it's very hard to kind of break free. Think about this in this way: our fear pathway is a 8-lane paved highway, something that makes us fearful. Zoom, we are on it. But our solution highway can sometimes be a really weeded path. And what we're wanting to do is help people bring that up and like, oh yeah, there was a time I felt similar to this, and I did find that this exercise or this tea or supplement helped. What we're doing is lighting up that area of the brain to help that weeded path become more of a road. So asking people about past successes, trusting their innate nature to understand their power. So I'm hoping that this kind of doctor help, if you will help you like, oh, I can actually do brief therapy in a really effective way that I'm utilizing all different types of theories to be effective and yeah, I'll stop saying brief.
Okay. So stage of change, something you can use often. So I encourage you to learn the stage of change, know it, teach it to patients. Like you can say, hey, this is kind of how we know change works. Let them choose what stage they're in. Talk to them about there's a lot we can do while you're in this stage. It can really honor where somebody is. It can also make sure that we're not trying to support them from a different stage of change. Use this with patients. You can put this in documentation. This person is currently in contemplation stage of change. And so we really explored kind of how they thought they could do or explored the pros and cons. Also use stage of change in your mind on the integrated care team. Where's this provider? Where's this nurse? I promise it'll help you. It'll help your compassion level. And anytime I felt frustrated after a session, that happens. We're not robots, right? It's often because I'm like, oh yeah, I was trying to support them in the action stage of change, thinking about what steps they were going to take or find new things to do. And that's not where they're at. They're still in contemplation. Or maybe they were at action stage of playing change last week, but now they're in contemplation. So it can really be something that's helpful in that way too. This next tool is really a brief action plan. So just to say brief again, and this is really how you can end your session with someone. Like, hey, is there anything you'd like to do for your health in the next week or two? Right? They might have an idea. So if they have an idea, you're like, cool, could we explore that a little bit? And then we're helping them make a plan. What, when, where, right? If they're like, well, I'm not really sure, right? Then we might be able to come up with some options if we ask, would you like to hear a few things other people have tried? No pressure. Maybe you'll choose one, maybe you won't, right? And if they're like, not really, I would say, you know what? Thanks for just sharing where you're at. That is totally fine. We can check in about it next time. So this is very brief, but it can go a long way because for the patient, they've talked about a lot of things. They may have seen a couple people just during their visit that day and you're one of them. And this can really help them walk out with somewhere. And I'd always end with that blue question you see at the bottom. How confident or sure do you feel about carrying out your plan? So that we can get that logical part of the brain online, as Russ just said, and then that also helps us make more, shore it up if we need to, or even say, wow, you're a 6, how come it's not lower? And give them like even more of a confidence boost. Well, I just really feel motivated. Or, I think I can do this. I've done this before. So this is a great way to end a session. This is another, what I would consider motivational interviewing tool. This could work for anything. This is just a picture of diabetes, but you can use this for any health issue or any other complaint. But it's really, you're saying, hey, there's lots of tools that you might be able to use. Why don't you cross out any of these that you don't want to do? And go ahead and let that person draw a big X through physical activity, right? If that's what they want to do. But what they're seeing is that there's options. Maybe they pick one and we can make that brief action plan. And there's also seeing that they have choice because there's some blank ones there. Checklists often work great. You can just make a checklist and you can say like, hey, here's some things other people like to explore. Go ahead and check off which one of these might be helpful for you. This is one we made for COPD in a clinic in particular to say like, hey, how would you like to learn? And it's really empowering them. They see that there's lots of options. I've never had anybody pick none of them before. But you also have this option of like, I've got my own ideas or something else entirely. So it's really this picture that this is collaborative and that you're working with them. And that might be different than their experience with anybody else they saw at the clinic that day, right? Who's really telling them the thing that might solve things or prescribing something to do.
Thanks, Katie. I briefly talked about solution focus, but as we talked about at the very beginning with the objectives, it's just to show about how some of the theories that you're learning can be easily integrated into what you're doing. And solution focus, I think, is well suited for integrated care. I know it's commonly covered in the family class you take, but can be covered in the individual theories as well. But it's a constructivist approach, meaning that we honor the fact that clients are experiencing essentially their own reality that they're constructing based on what they've experienced, and then the stories that get built based on those experiences in their life. And kind of what solution focus is saying is, hey, you can question those stories now. You're allowed to change those stories. So solution focus and narrative therapy are very, very interrelated, and that we're probably maintaining our reality based on stories that we're not even really consciously aware of. And are we willing to kind of look at that? So just be aware that we can use these theories that we're learning to integrate in. And I think if you go back to the doctor help slide, you'll show kind of a functional way of using some solution focused methods when working with clients.
Okay. So this slide is about COPD, and we used some of what you see with a client that I saw who was an older woman, and she described herself as Spitfire, and y'all, Spitfire she was. She could show up in a way that created a lot of chaos places, and she really struggled with anxiety. She also did have significant COPD, and she really, really had trouble being by herself, really struggled with loneliness. And this was in a rural town about an hour from where I'm sitting right now. And the place that is open after hours is the ER. She would tell me that. That's where the lights are on, right? And she wasn't wrong. And she would go to the ER, and although she could make things happen and was assertive and confident and funny at times, she looked like everyone's like sweet grandmother. So she would show up at the ER looking like the sweet, frail lady and say, "I'm having trouble breathing." And all of the medical team would jump in, right? And she would end up at the ER. She would be there a long time, these bills. And she had been to the ER just so many times. I mean, dozens and dozens and dozens. And we were able to start working with her. And we used this card in concert with her primary care provider, because I'm never going to be the one that says, "Oh, I think you're breathing fine," right? I'm not a provider, I'm not a doctor, but who helped us really go, okay, what's green, what's yellow, what's orange, and what's red. We also got her a pulse ox, which could measure how her breathing was, worked with him and the ER. We all had a formal written plan that we knew that when she showed up at the ER, before anybody checked her in, they would first call our crisis line. She would do her pulse ox at home. The person on the crisis line would give her some support. She would try some tools, assuming the pulse ox was okay. And we were really able to avoid a lot of ER admissions, right? As we helped and supported her working on her anxiety and her loneliness. But there's lots of cool tools where you can learn a little bit about something, get some guidance, and make a really big plan with someone. So shared decision-making. So shared decision-making really is about how do we empower patients to be more involved, and how can they start to weigh in on their decisions. And we can be really a key player in this, and helping make sure we know how do they make decisions, is also what information about options are they given. We're really saying like, yeah, let's make some time. We might not have to, if this is an emergency, we don't have to decide right now, and really help walk them through making this decision together. When I learned about this, I took a class in shared decision making, and the woman that taught it told this story that always sticks with me, where she and her partner, her husband, they both had cancer, like both got diagnosed within several months of each other. If you can imagine, it was very hard. And she went to town on research. She like holed away for days, did all of her research on the type of cancer she had, where she wanted to get treatment, what type of treatment. And then she printed out articles and articles and articles for him to do the same. She said she got very frustrated at that they just sat in a stack. And what he ended up doing is he went to his primary care doc, who he knew very well, and said, "Hey, if this was your brother, what would you do?" And the doc said, "This is what I would do." And he said, "Okay." Primary care doctor was not the oncologist, but it was just this reminder that we all make decisions very differently. Same thing in my home. My partner will make an Excel list of, like, I'm not kidding, like 30 columns to buy a coffee maker. I would ask two people that I trust, and I'd go off and buy a $12 coffee maker, right? So understanding how our patient wants to make decisions can be a really important thing in their healthcare, and validating that we all make decisions differently. And that's what shared decision-making can be all about. There's also what they call decision aids. So there's many of these out there. You'll see this one is very specific to taking a depression medication. This is online through the Mayo Clinic, and you could really look at each medication and look at the side effects. What's going to happen with my weight potentially? How will it affect my sex drive? How about my sleep? How much does it cost? What happens when I'm stopping? So someone can really educate themselves and talk about what's important to them. And we can be a good support in helping them bring that to their primary care appointment. There are decision aids on medications, on treatments. There's also even one on employment for people considering going on disability. They get to kind of weigh the pros and cons of what that might be like not to have a place to go, or a work to do, or volunteer work. So these can be really helpful in someone's care as we help them make decisions. When I was learning about this, I think I told myself, like, well, I'm a counselor. Like I'm paying attention to what's most important to the patient. And I think this was really helpful in knowing that sometimes I miss it, right? Sometimes I have an assumption about what somebody wants or what's most important to them. And these can really help almost have a third party between us, the patient, and this decision aid that helps become clear what's really important to them. This is just a picture. This comes from Peter Levine, Diane Poole Heller, and really it's a way to think about stress and trauma and also our health in the nervous system. So when we're thinking about that somebody has a lot going on, you see this lightning bolt. This can be a trauma. This can also be the everyday events and stressors that when we're in that light green place, we can connect with others. Our brain is working. I can be creative. I can think about the future. I can weigh logic, right? That's happening in that green zone. But when I get bumped out of that green zone, I can either get on amped up. So this is our fight and flight response. I'm anxious. My mind's moving really fast, right? I can't calm down. Or that stress could be so overwhelming that I get bumped on shutdown, that dark green, which is really like I'm foggy. I can't think that clearly, right? And when I look at this model, this is something you can use for yourself, also for the team and for patients, but it's really something easy that you can share with anybody to say like, oh, has this happened to you? This is how all of our nervous systems work, that we all get stressed, we all have these jolts, and we all get bumped up on amped up or shut down. Hopefully it's just for a minute. We don't want to live out there. That's where it really can be damaging to our health. But this has also helped me look at the person in front of me and think, okay, where is Russ right now? Oh, he's really amped up. So I'm not going to try to help him fill out the paperwork right now. We might just stop, take a breath, look around mindfully before we move, right? Or it may be that a nurse or a doctor is explaining something to the patient and you're like, if I had to guess, they would be on that shutdown. Like their eyes are glazed over, they're not making eye contact. They're so overwhelmed, like they're signed off and there is no information that is settling with this person, right? So we can teach this, but it's often a way just to pay attention to where we're at. Okay, before I sit down with this next person, before I enter this exam room, let me make sure I'm in that resilient zone so that I can take in information and connect with folks. And the science behind that is really that hand-brain model. So how many of you have heard of the hand-brain model before? See a couple hands, awesome. If you haven't seen this, you can look up Daniel Siegel hand-brain model on YouTube. You'll find lots of people doing it. But it's really a way to think about and teach people what's happening in our survival brain down in our wrist, right? Things I don't have to think about, fight, flight, and freeze, my heart rate, that my emotional brain is really attached to the memories and anything I've ever been through, which is often even when someone walks into a primary care clinic or a mental health agency, their brain is pulling on their past experiences and bringing to the forefront, that we all have this amygdala, we call it the smoke detector, that's constantly scanning for safety or danger. Right? If you ever had to get blood drawn or a vaccine or a shot, you're sitting in that seat and your eyes are looking all around that room. It's just what we've read everything on the walls by the time the doctor has come in, right? That is our amygdala that's sort of scanning for danger, but also for safety. Our thinking brain is our fingers, which hopefully our brain is working like this, where it's using all the parts together. But when we get that jolt, as we saw on the previous slide, or the amygdala feels danger, we flip our lid and thinking brain literally goes offline. So that's where language, that's where understanding, where we can do impulse control, where decisions are made. When our lid is off, we can't do any of that good stuff. And so we want to think about whose brain is online. I teach this to almost every patient, especially to parents, so they can understand what's happening in someone's brain and nervous system when their brains go offline, and why it's important to help get our lids back on before we try to share any information or do any interventions. So certainly as our world ages and as we're in integrated care, we start to see folks that are struggling with cognitive decline. And so these are just a couple tips as you think about that, but really encourage you to learn more about that, that there is value in assessing where someone currently is, that we really can say to someone, you know, it might be good to just get a good screening right now, so that we know where you are later. It's great if you're in an integrated care setting where there are psychologists who can do some neuropsych testing or a neurologist referral, but there are some screening tools that you can use, and encourage you to get acclimated to one of those. There is one I'm from St. Louis. It happens to be St. Louis. That's just a couple questions that you can use. That's just asking people to get a baseline to let you know, do they need some further testing? To keep in mind, there are lots of things that could be contributing to cognitive decline, and we don't want to make any assumptions or jumps. We want the whole team in a primary care place to be involved. Could be traumatic brain injury, could be addiction. It could be this person is on so many medications, we have no idea what they would appear like if they weren't on that many. Could be the side effects, could be stress, could be trauma. And it certainly also could be Alzheimer's or Lewy body or some other form of dementia, but we just don't want to make jumps. We know that it complicates care if the person that you're trying to communicate with is having some cognitive decline. And so we want to be aware of that. We want to really pull in family members, and find ways to really provide support and some follow-up, that we may need to get other people's input to really understand what's happening. To also, I love the saying in Alzheimer's that there's two patients. It's the person that it's happening to, but it's also the family member that is now trying to adjust to this new change, and perhaps an older person who's now taking on tons of household chores that they never had before. So it does impact the whole family, and we want to provide that support to the whole family. And again, really relying and making referrals to those specialists that specialize in supporting cognitive decline.
And Katie's got a good video that she created, just kind of how to kind of introduce that, and particularly just paying attention to the second patient, which is the person taking care of their loved one who is slowly forgetting them. With sleep hygiene, I suspect many of y'all have issues with sleep. This seems to be almost an epidemic. Clearly, your clients will. And just be aware that we want to always ask the motivational interviewing piece at the very top is we want to ask people what they've tried. Ask them if they're willing to, if they'd be open to accepting some suggestions or looking further. That would be the advise. And then after you offer some suggestions, elicit again to how did that land with you? Do any of these kind of make sense? It would be good. This would be a slide I'd love to change and just kind of like show you like a checklist that we could present to clients like, hey, which ones are you using? Which ones have you tried? For how long did you try it? Would you be willing to use some other types of tools? And so you see some kind of simple tools, for instance, chamomile tea. I personally use this now, but I think it's got a cumulative effect. So it's like a little bit of me developing a ritual, like, okay, at 9 o'clock every night, I'm going to make my tea. I'm not great at turning off the TV. It'd probably be good to read a little bit, but what are these kind of winding down rituals? Using an eye shade when we sleep so light doesn't bother us. Magnesium is fairly safe. If we take too much of it, we're just going to go to the bathroom. And I've heard, NPR just did a story on it, is that magnesium is, kind of a relaxant, if you will. I don't think it's, I think it's something that they say that we may be a little short of, due that we're not getting a lot of it in our foods. So, maybe some mindfulness practice. I know in the positive psych class, we talk about when your head hits the pillow, just kind of being thankful for some small, unique things in the day, just eye contact from somebody or a smile or maybe a text message. So this would be something clearly collaborative with the client, but just acknowledge that sleep's a big issue for a lot of people. And I also want to say is that this is definitely an area where if people are having ongoing chronic sleep problems, that medication can be very helpful and is needed because sleep problems are correlated with stuff like dementia and even potentially brief psychosis. So this would be a case where if it was ongoing, I would definitely want to take medication very serious about this. Anything else you wanted to add on sleep hygiene, Katie?
No.
Okay. And I think we've got 7 minutes left and just a few more slides, just a couple more. But,
Yeah. If you are doing integrated care work, you will be doing addictions. You can't opt in and opt out, right? It's just another health issue that many people struggle with. and you'll be doing a lot of harm reduction. And so getting familiar with that, I will say sometimes the providers may not have had the same training that you might get on harm reduction. So that's something that could be new for them, not all of them. Lots of motivational interviewing and this, let's do this together. This is an experiment. Okay, it sounds like you want to drink less. Let's see how it goes. Let's make a plan and you give me feedback. This isn't a pass or fail. That's really the spirit of collaboration we want to use. And then really using those rulers. I have lots of folks who have laminated them and they carry them in their back pocket if they're going to exam rooms, or they have them available to really let people look at these rulers and say, yeah, this is where my readiness is, or this is where my confidence is.
And checking in with clients at the end. This would be quality assurance using a session rating scale. And the next slide will show you it's a very simple scale to use. It's been shown to reduce early termination with clients. I want to particularly point out it reduces formal complaints against mental health professionals. So getting a complaint from a client can be incredibly stressful. And if you're using a session rating scale at the end of every session or most of your sessions, you're making clients aware that you're interested in how this is working for them, and you definitely want to collaborate with them to find out how to work best. So maybe if we can look at this next one. These are in the public domain as well. There's one for children, adolescents, and even young children that just have kind of emojis. And they're using a visual analog here because numbers sometimes freak people out, but this actually can be measured for research. Somebody would just put an X, like, oh, I felt understood and respected. We worked and talked about on what I wanted to. The therapist's approach is a good fit for me. And today's session was good for me. But it's just a way of it's actually, I think, a very helpful therapeutic tool because it allows the client to see that we're working together. This is a collaborative effort. This isn't me treating you. And let's make sure that we're working well together. So a good quality assurance measure, very simple to do.
Russ, do you want me to pause here or click to the next slide?
Oh, you don't like this slide, Katie. Let me just, I'll tell you what we'll do. Let's just click on the next two quickly. I just want to make, I do think in the counseling profession that we don't spend enough time talking about kind of dark triad personality traits because these are going to show up. Not only that, it's a small percentage of the population, but clients who've been affected by people who have high dark triad traits. And if you're not aware of what these are, such as the narcissism, psychopathy, Machiavellianism, then it could wind up placing some shame or blame on the client for like, oh, I guess I'm not trusted in what I experience with a boss or with somebody. So I like to put this slide because I do think this is a kind of a bit of a weakness in the counseling profession, perhaps because we focus so much on wellness but it's not, I don't think it works to say, oh, psychologists and psychiatrists are going to deal with that, not me. No, I think you're going to see this in your practice and even in integrated care. And Katie, if you can go to that next slide, the last one, or the next one. This was a great book that I didn't know that I was going to like, and I read it this summer, and it gives a very human viewpoint on what she calls sociopathy, which ultimately would be less than full-blown psychopathy. And I know that sometimes that's called secondary psychopathy. So there's all kind of terms that confuse us. But ultimately, she said she would act out, even as a kid, to feel. Is that the part of being a human being and not feeling? She knew she had ways to do that. And of course, I think we would all do that. And then she also kind of inadvertently talked about therapeutic aspects. She went to therapy, but normalizing her thoughts, cognitive restructuring. This is a video I put out as well. Some mindfulness things, some dialectical behavior therapy. I would encourage you to learn as much as you can about dialectical behavior therapy. But just those last two slides to be aware that I think this is an area where counseling profession can kind of boost itself a bit, is to learn a little bit more about. And that is it. And we did a little better time with time management than we did last year. So I appreciate you being here. These are ways that you can reach us, and I'd be more than happy to answer emails. Katie as well. She works for Resources for Resilience. And I just very grateful that you had us back again. I hope it was helpful. And I wish you the best for this semester. And I hope it's not going to be too terribly hot.
Okay, thank you so much, Dr. Curtis. This was really, really helpful. And thank you so much, Katie, also for joining us this morning. Well, so right now I'm gonna be putting the recording on pause. And then if everyone would like to just come back like around 1, that would be great. Other than that, I'll see you in a bit. Thank you so much, Dr. Curtis and Katie.
Oh,
Thank you
absolutely.
again.
Bye-bye.
And Katie, really quick before you go, because I haven't been able to get a hold of you for payment, I just took down your email.
Hi, Dr. Salazar.
Hi, Dr. Mata. How are you?
Doing good. Okay, so we're just, let me see, I think there's a few students still in the waiting room. Okay. So I hope everyone got to have some time to maybe eat something or, drink water or just like stretch or something. I hope you weren't just sitting there in your desk. But yeah, so for this second part, we have Dr. Salazar here. She's going to be presenting on understanding social determinants of health as a clinician in integrated care and beyond. And I'll let her introduce herself and kind of like tell you what we're going to be doing for the next 2 hours. Let me make you a co-host. Dr. Salazar. There it is. Okay. Okay, I just gave you the privileges. You should be able to.
Okay, great. Can I have thumbs up or emojis from people if y'all can hear me? Excellent. Good morning, Beth. Okay.
How are you?
I'm well, thank you. I'm hot. I just came from a do I just admit people when I see them? I'm just gonna do it. You made me a co-host, so I'm just gonna do things.
Yeah, it's fine.
Okay. Are we all students? Do we have licensed clinicians? What do we have in the room before I get started?
Student.
I want to say there's probably like 2 clinicians from what I'm seeing, Beth, right?
Yes, majority are students, and we have about 2 or 3 clinicians.
So I know what I'm going to talk about. Okay. All right, so I will be mindful of y'all's time. LPCS, thank you, Michael David. I should put my cheaters on. Okay. Wait, let me share my screen. Y'all think I would know how to do this, right? Start my PowerPoint. So good afternoon. Thank y'all for joining. It looks like y'all have already been online for a while, so I will not dally. Okay, another thumbs up if y'all can see my screen. Excellent. So for my 2 or 3 clinicians in the room, some of this might be repeat for you, but some of it might not, because I don't know about y'all in your training programs, but I did not get any training at all on social determinants of health or integrated care. I just kind of had to get some real world experience. So And I think that's why I like to talk about this topic, because it's so important to know about what these things are, not just in integrated care, but kind of just how it impacts people's lives in general. So I'm really grateful to Texchip to bring these topics up. Not just the other stuff, right? The anxiety, depression stuff, but also these things that really impact clients that we don't really think about, that aren't really touched on really well in our textbooks. So my name is Dr. Ana Salazar. My pronouns are she and her. Today we have just 3 objectives, just really short, because we're going to define some stuff. We're just going to kind of talk about the impact on mental health care, kind of analyze and think through what we're doing, and we're going to try to apply a validating approach to what we're doing and talking about. I do have some guidelines for when I teach and when I present, if y'all are not familiar with me. If you're familiar with me, y'all have heard me say this a billion trillion times, but there's a parking lot rule. I'm kind of excited. We got 2 hours because I do accept questions. Stop me. We'll take the PowerPoint off the screen. We'll have a discussion. I don't mind, because we're not going to learn if we don't talk about stuff, right? But sometimes we can get distracted because we're counselors and we talk. So I keep a little pad of paper with me, and I might put it in the parking lot. Not that it's not important, but just that we might need to pause it. We'll come back to it. We'll circle back to it at the end. And the other thing the other rule kind of tip that I have when I teach or present is that, and my students hate this, and so do clinicians when I talk to them, I don't have all the answers because we're working with people. We're not making teapots. We're not building cars. Sometimes it just depends. It depends, and sometimes I don't have an answer. Sorry. And sometimes that's going to be the answer. That's it. So who am I? If y'all don't know me, I have experience working in an inpatient behavioral hospital. I worked as a mental health tech for a couple of years. I also worked at MHID. Back then it was called Behavioral Health Center. It used to be called MHMR. So providing local mental health authority services. But I was a case manager, and then I ran the rural, that's my least favorite word, rural mental health clinic over in Robstown. Adolescent, adult, children, ran the site clinic, all those things. Also been associate director at a university level, running a counseling clinic. I'm also a community advocate. Right now I have a private practice. I'm also have my PhD in counselor education. I'm not adjuncting this semester, but I have before. And I've also personally been a recipient of some of the services that we're going to talk about when we think through social determinants of health. And so when that's important, I may self-disclose, because sometimes I think stories help people to understand what's going on. And I've just been through some of the systems. And again, I have personal experience, and sometimes it's hard to get through some of these things and to understand social determinants of health if you don't have some of those understandings. As always, questions, comments, concerns, just let me know. I have 2 monitors, so I have my PowerPoint over here looking at it, but I do have a screen up over here with y'all's faces and things. So just pop up a little question hand thingy, or put it in the chat, or just unmute yourself. I don't care. I don't mind. If y'all have questions, please stop me. But why are we here? We're here because there's sort of a disconnect that I've seen in working with the populations that I work with, and just being a client and being a counselor, between working in integrated settings, getting clients the care they need, and kind of the understanding that we have with care. And there's sometimes limited training. It's almost this expectation that counselors need to come into the field already knowing how to navigate systems themselves and how to work within integrated care settings. And there's a lot of biases and stigma, both within ourselves as clinicians and just as consumers of care, about what care means. And we'll discuss more what care means as we go forward, but care could be anything from medical care, mental health care, social services care, and just kind of the whole spectrum of stuff. I've seen biases and stigma against all sorts of things. We talk a lot about mental health stigma as counselors, but not really social services stigma and the stuff that you would need to access care if you're working in an integrated care setting. And sometimes there's also ambivalence and misunderstanding about what integrated care means, even within that setting. And there's also challenges and barriers within integrated settings and outside of integrated settings on accessing all the things that you need. So I'm going to give you some specifics of what integrated care means, of course, but it's not a one size fits all. It's not a one-stop shop like it's supposed to be. So there's inherently challenges and barriers. One of my mentors always taught me to think through problems and think through presentations and writing when I'm explaining things or teaching things as what, so what, and now what. So that's how we're going to talk through these things. We're going to have a what, a so what, and then now what. But first, I stopped sharing on purpose so I could see all y'all's faces. What kind of work do y'all do? Y'all, I'm not just gonna let y'all just sit there and like stare at me or just stare at the screen. What settings are y'all in? What locations do y'all work in? You can put it in the chat if you don't want to unmute yourself, but talk to me. Or are you going to be practicum?
I was like, I'll go. And
Thanks,
then
Bethany.
to follow, please. Well, as of last month, I was still working at the CTC there on campus, but I have had experience at the juvenile detention center. So those were like two like completely different populations. So it's a good mix of experience there.
Yeah.
Hannah said the UCC, and Clarissa said case manager at MHAD, and now she's doing practicum at Oceans Behavioral Health.
Okay, so Clarissa, I'm going to be preaching to the choir a little bit. So Jess needs to know all the resources.
Psychiatric private practice, inpatient psych hospital and private practice.
Okay, counseling practice, inpatient, CCPD. What's BAPS? Remind me, I'm drawing a blank. I know what the CIT officers are. What's BAPS?
Bay Area Psychiatry Services.
Thank you. They changed the name. It used to be. See, that's a challenge in itself, is when acronyms change and when departments change or merge and stuff. Like, okay. So a mix, but it looks like nobody's in a integrated setting or truly integrated setting. I know psychology associates. My office is literally behind CARD, the Coastal Center for Autism and Resource. Center for Autism Related Disorders. Okay, so nobody's in integrated care. Okay. All right, so never mind. Y'all look kind of quiet. That's right. I'm going to circle back to y'all. But that's okay. So we have a wide variety of people working in a wide variety of things. Put numbers in the chat, scale of 1 to 10, 1 being like, I don't know nothing, and 10 being, I got this, I'm super comfortable, I understand everything. How comfortable are you with SDOH related to client care? Social determinants of health. 1 is, I don't know, and 10 is, I got this. Six, five, 4, 8. Okay. That's a pretty decent average. Okay. So then what would be most helpful for y'all to learn about today then? Because I can teach on the fly too. What are y'all worried about?
I'm not too sure how you are going to teach it, but I think my rating came from the fact that I'm aware of SDOH and like the concept, but like being able to apply it, especially in the stage that I'm in my counseling development, I don't know if I really know how to like um implement the knowledge that I have on it into my practice and like into an integrative setting.
Mhm.
And like just kind of like the roles and responsibilities and making sure that I'm doing my role well, but being able to like also take into account the other roles that are present.
Mm-hmm. I'm going to write down this one, integrating spirituality. But how to really use your skills as a counselor in order to implement the knowledge of SDOH. Anybody else? That's great. I am going to talk about that because we don't talk about that. But anybody else? Trevor?
Yeah, I guess for me, how to be more efficient with like finding resources to improve SDOH, and then like, how to, connect clients to those resources. Because a lot of times when I'm like digging for like community and local resources, it feels very like unfruitful, and especially with us being students and if we're at multiple sites or just having other assignments, it's like, okay, dedicating that time to like find those resources a lot of times just feels very like inefficient. And it's like, man, I have a million other things I could be working on. And yeah. And then so it gets to a point where it's like, all right, maybe I'll find like one thing, but I guess like ways could be other like websites or just whatever, just better strategies to like find those local resources.
Okay. I make no promises, no guarantees, because this is the hard part, right? We talk about these theories and these concepts of what we need as clinicians, but then implementing it is really hard, especially when we consider things like SDOH and things that clients need to bridge that gap of care. Because we have this book knowledge, this technical knowledge of what we're doing, but the application is really difficult, especially because this is kind of one of the areas that counseling doesn't do well, which is the basic real life stuff. We'll get into it. I have some tips and some suggestions. I also have some feedback and some thoughts, but I'll circle back around to some of these things. So that's good feedback. Thank you, because I need to know what to talk about. Because if not, I'm just talking to little black squares and y'all aren't going to get anything out of it. And that's a waste of your time and a waste of my time. So good. Thank you. Again, I make no promises, no guarantees. It depends. But let's get into what I have and I'll try to integrate these stuff into there. Well, let's go. Dr. Mata, Bethany, any feedback, concerns, questions about that? No? Okay.
No, ma'am.
Okay. They're my bosses today, so I'm just checking in with them. Oh, wait, I gotta share again. My bad. Share, share. Make you all bigger. Okay. So I'm just going to go over some brief definitions just to make sure that we're clear and on the same page, because it looks like we're kind of all in different things. We kind of know what integrated care is, that it's this healthcare delivery system. Hold on. Oh, excuse me. The challenge that I see, even when I'm doing research on this is one of my initial dissertation ideas, and I scrapped it because I wanted to do something else. But there's a definition for integrated care, but how that delivery system is given is so varied. Like there's no one model for delivery of care, but it's technically supposed to be like one co-location, one building, a one-stop shop, kind of like a Walmart, where you can get your tires done, get your groceries, get your medications, all that stuff together, with the idea that we're giving positive healthcare outcomes with a unified way. That way it's more cost effective, it's less hustle and bustle, It's more cost effective for the clinicians, the providers, and most importantly for the patient, right? The person receiving the care. Whoa. Are y'all still seeing my screen? Okay, I clicked the wrong button. In reality, what we end up having is kind of this mishmash stuff of something that tends to be more either coordinated or co-located versus truly integrated. I'll even share I took my child for his 12-year checkup this summer, and it's coordinated care, I guess. I think this was the first time that he had to fill out a PHQ-9 by himself. Thank goodness that I know what a PHQ-9 is, but there was another mom in the lobby filling it out with her kid. And she's like, why are they asking us these questions about your feelings? And what do you mean, like you want to whatever? So I kind of explained it to her. And I didn't think about it because we had other stuff going on that we had to ask the doctor about. But like, what if he had scored real high on it? Would we have had resources? I guess so. I mean, I don't know why they're doing it, but whatever. I'm going to call her to actually ask. Now that I was preparing this presentation, I was thinking, oh, I should probably ask, do they have resources? Why bother doing that then? But there's definitely sections of stuff that they do at that office for that care. I don't know. Let me stop that story because it brought up more questions for me than answers. But I guess that's supposed to be coordinated care. They're going to have referrals and things. Co-located might be something that we have here locally in Corpus, like Amistad or Driscoll Children's Hospital, or even the Robstown Clinic for MHID. Their main clinic for the mental health services is inside of the Nueces County Indigent Clinic. But they don't share the same medical system, the same charting system. So truly integrated means that they use the same charts. Everybody has access to the same things. If client Sharon is going to see the medical doctor, the counselor can also see the same chart. The pharmacy has access to the same chart. The physical therapist, the cardiologist, everybody has access to all of the same information. Now, they could be zoomed in to see a psychiatrist or something or a therapist, but they all have access to the same things and they all follow the same protocol. That's what true integrated care is. Questions, comments, concerns? Right, like, is it Michael David? It says Michael David. Yeah, if he scores high, do they call CPS? Do they get somebody else involved? I don't know. I need to call and ask. Next time he goes for a checkup, I'm going to have to ask them what their procedure is, because why even give them a score? Why have them screened? Questions, comments, concerns about what the spectrum of care is. A lot of facilities call this stuff all integrated, but it's not really. Only the far right, the gray column, is truly integrated. That's what we're supposed to be working on. But there's no one pure definition, and again, no one delivery of care. So let's define social determinants of health and briefly talk about their impact on mental health care. Sounds like some of y'all kind of know what it is, but I want to make sure that we're all on the same page and that we all know exactly what we're talking about. So the CDC definition is, conditions of the social, physical, and economic environment in which we live, work, and age. It's all the policies, institutions, all the other aspects of the structure, and community factors. So break it down. It's our childhood experiences, our housing, where we live, our social support, access to health services, our communities, how much money we make, our SES, socioeconomic status. All of those things are considered social determinants of health. And if you wanted some examples of some of these categories, they all kind of merge together into one big category. Under neighborhood and physical environment, for example, it's like your housing, your transportation, your safety. Like, do you have access to food? Do you have food insecurity? I already said that. For your education stuff, like what's your literacy? I wish this was updated. Like, there's also media literacy that's coming up now, right? So all of these things kind of impact what our health might look like. Questions, comments, concerns? So what? So what? So what? Oh, so y'all, I need to apologize because I literally got a new laptop. And so I'm learning my mouse. I'm such a dweeb. No, I'm sorry, dweeb is probably a bad word. So why social determinants of health? So this is Maslow's hierarchy of needs. Y'all are familiar with this. We teach this a lot. I'm going to add an asterisk because there is some discourse currently, and for the past like 5 or 6 years, about whether or not and where Maslow got this from. And it's reflective of probably the Blackfoot Nation and kind of their teachings and how he may have flipped it around and whether or not it truly was what he was intending for this material to be. So I have not dug into that research. I have not looked at the reflections on the Indigenous community, on where it came from. So just acknowledging that there is discourse there, and I have not done enough research on it in order to talk about that thoroughly. So the asterisk is that we're reading about it, and we still teach it this way. So y'all understand this way. So why SDOH? Well, because who cares about self-actualization and who cares about what your relationships look like when you can't feed yourself? So, I mean, I get hangry just as a whole adult, right? I need a juice box and a nap sometimes. I'm not gonna lie. I don't lie to people, I don't sugarcoat things. But, much less having consistent food issues, consistent pain issues, consistent lack of housing, right? Who cares about talking to a counselor about all of my emotional needs if my physical and safety needs are not being met? Literally, honestly, truly. And sometimes this is a big disconnect for people in helper fields who kind of like, well, no, they come to counseling for this thing. No, boo, they don't care. They're hungry. Just saying. And there's all these layers within SDOH that unless we're really, really considering them as clinicians, it's easy for us to miss the mark. And I don't care which theoretical foundation you come from. It does not matter if you're narrative or if you're humanistic framework or if you're thinking things totally just cognitive behaviorally. It doesn't matter. You can still conceptualize someone's humanity and someone's existence in this world and still reflect on how were they brought up? What access do they have to food? What does their life expectancy even look like? Can they even get to your next counseling session? There's layers and there's depth and breadth to someone's life, no matter what your orientation is, whether you're treating them with an integrated care system or not. And this kind of goes back to the wanting to integrate spirituality and religious organizations into this stuff too, is that if someone's not thinking intentionally about spirituality or what that looks like for that person, if that's something that helps support them within this SDOH spectrum, then that's something we got to hook them up with, right? We got to think about that, even if that's not our perspective, or even if that's not what our theoretical framework thinks about, that's still going to be a support for them, right? So it makes us reflect a little bit more on the depth and breadth of people more than just treatment goal intervention or objective interventions. Oh my gosh, I just made it harder for my students.
I have a question.
Sure.
So how would you support their spirituality, like as part of their needs?
Well, I would ask them what they need. I'm trying to figure out how to stop my share screening. Hold on, I'm sorry.
I had one client,
Mhm.
And he constantly asked me if I believe in God or not, because for him is very important.
Mm-hmm.
This aspect to as part of the recovery process.
Mm-hmm.
So I wonder how you manage that.
Well, if you're not comfortable with sharing your spirituality, then you can redirect and support that person in finding care that does support the spirituality. But if you do feel comfortable and you have the training, then you can integrate it into there.
So in the spiritual aspect, if you have the training, you can support. If you don't have the training, I don't have the training, so that means I cannot support.
You can direct and support him to resources that can integrate it, but you can also integrate it in the way
Yes,
of
of course.
like your homework or supplemental resources. And if it's not your scope of practice, if you're just assigning it as homework, like maybe you're going to, well, that sounds like that's super important to you. So what does that look like for you? Are you going to be going to mass or church or whatever that spirituality looks like? Have them define that. Exorcisms. No, you can't do exorcisms in a counseling setting. Maybe I need to open up the chat so I can see what you're talking about. Yeah, whatever's in the scope of what you're assigning him to do and what he's wanting to do for homework. If he's asking about his spirituality and how he can blend that into his recovery, then you can ask him what he wants to do with that. And tell him, be very specific. Do you want to go to church more? Do you want to talk to your deacon more? Do you want to pray more? Do you want to buy a devotional book? Do you want to, instead of journaling for homework, do you want to write in your devotional every day? Things like that.
Yes, I think my question was because I hear you saying, talking about supporting them in their spirituality. I understood that, like, I'm not sure if I understood correctly. So I was curious, how do you handle that practice? So from there was my question.
How do you handle it from there?
No, like, since you mentioned that we can support their spirituality, so and spirituality is very complex. I was wondering, like, well, how you handle that in your private practice as a professional, and so that was the question, I think.
Yeah, I have them define it for me. Tell me what that looks like. Just like I have somebody explain what anxiety looks like for me, because every person is so different. What does that look like for you? Explain what that looks like for you.
Thank you.
Okay, so what? So what are we gonna do? We're gonna talk about stages of change. Are y'all familiar with this? Everybody has seen stages of change. We talk about this a lot. Well, we talk about this more in maybe substance use kind of criteria. But this is also helpful to reflect on when we're thinking about how are we going to get social determinants of health people through resourcing and through what they need when we're considering integrated care, considering counseling, considering these kinds of needs of social determinants of health. Let me show you why. There is very, very definitely a connection between stages of change and what somebody needs to have access to. Let me show you why. We often think of, oh, I did all my research, Trevor, and I found all these great resources for somebody, and my client didn't do it. Or I can't find something that someone can get. Or maybe there isn't a thing, right? And sometimes the client may or may not even be ready for it. let's take an example. I walk through an example. Say a client is in a truly integrated setting and they've been meeting with the doctor and they are seeing you for counseling. And this is my note. The little blurb in the bottom is what I wrote in my therapy note. Client referred to local food pantries to assist with food insecurities and assistance with nutrition due to escalated cholesterol and impacts of diabetes management. The client verbalized agreement to reach out and set up recurring appointments to referrals provided. I gave them referrals to go to the food pantry. Client said, yes, they're clearly in action stage. They're ready to go. I gave them the food pantry flyer. Maybe they come back a week or two later. They denied attempts to access food pantries. They have increased frustration. But they said they'll follow up next week. I didn't do it, miss. I didn't do it on I'll do it later. And now also as a therapist, I'm also noting that they have increased isolation and low moods. And now they feel like a burden they report feeling like a burden to their family, and they're feeling more low lately. That's within my scope as a therapist, and I'm still noting that within the integrated care setting. And now I'm kind of noticing that they're within the preparation stage. They've kind of backed off a little bit with action, and they're saying they're going to do things. They're preparing to do it. And now they kind of relapsed, or, they're kind of still, maybe they're pre-contemplative. They could be either or, kind of depends. I'm now noting that they're ambivalent to further resourcing attempts, stating it's useless, like whatever, my diabetes is out of control. And now they're feeling hopeless regarding their physical health. They have increased isolation, and their PHQ-9 is now increased to moderate levels. And now all my red flags are going off as a therapist, and the doctor's probably super worried. All the red flags are going off, right? And now as a counselor, I'm probably forgetting about the food stuff, and now I'm worried about their PHQ-9 because that's how I'm trained. Now I'm worried about isolation. Now I'm worried about the depression scores. What I did yesterday is I straight up went to Facebook. Corpus Christi moms or mamas, I don't know what it was. I follow a couple of different things online. Corpus Christi moms group, and just looked up food pantry. And this is the flyer for last month. Oh, Tuesday. It's coming up this Tuesday for a food pantry drive. Right? Why can't my client go here? Corpus Christi mobile food distribution, Bear Lane. This Tuesday, on-site registration, distributions from 9 to 9:30 or while supplies last. Pre-register early by phone at this number. Distribution guidelines, have your QR code ready to be scanned. For safety reasons, stay in your vehicle. Please stay off your phones. Follow all traffic rules. Looks like they're giving out lots of stuff. And I've been through some of these before. During the pandemic, like I went through a couple of them myself. It's a lot of food. Let me go back. How do I stop sharing? I've lost my stop share.
I don't think you were sharing, Anna.
This whole time, y'all didn't tell me nothing.
I just right now when you were trying to like stop it, I was like, I don't think you were. Sorry.
Y'all need to speak up and tell me something. No wonder I can't stop sharing. What is the last thing that y'all saw? Was it like 30 slides ago?
No,
Wait,
I
It
think
was
So what? Yeah, that one.
that
The
one.
define.
so what?
Y'all, I can't with you. Anyway, this is social determinants of health, the definition. Here's a blurb about what they all are. It's a good thing I didn't like pick my nose or something, thinking that y'all could see me. There's depth and breadth. Let me just show you the flyer because y'all are listening to me. This is what I was talking about, stages of change. Y'all can see this, correct? Okay. This person is in action stage, talking about food pantries, insecurities. Preparation stage because they're going to follow up later. but now they've relapsed. And here's a lovely food flyer drive that I found yesterday. I'll let y'all read that again since I was reading it to you. I'm so embarrassed. That's okay, I'll accept it. I'm still mad at all y'all for not saying nada. There's my stop share. Okay, now I'm stopped sharing on purpose. What is the issue with this food drive and why is my client not going? Tell me.
They don't have access to transportation to get them to the food drive, or if they have children, they don't have the ability to take their children with them, or like childcare to take care of the kids while they go get food at the food drive.
I saw somebody else go off mute. JJ? Can't read English, power window's broken, can't stay in car. Oh my God, in grad school, my windows did not open. Yes, can't stay in car. It's hot. It's 200 degrees. I mean, we've lost 2 children recently. Like, no, can't read English. Oh, somebody's gonna get into audio. Anybody else? What else is wrong?
I mean, it only had like one date on there. So like what if somebody was unable to? There's no info of like a future one, you know, or a couple future, you know, upcoming ones. Could you put it back on the screen though?
Sure. Now that I know I'm not sharing.
Yeah.
I'm so salty. Okay.
They requesting a QR code.
Yeah, I'm not sure how to get a QR. From reading this, I'm not sure how to get a QR code.
Is it by the phone then? Where it says pre-register early?
Good question. I don't know. And why do they only have one little esta institución? It's just one little, there's no other directions. Pre-register early by phone, but do you still, anyway, I don't know where to get a QR code from. Do they email it to you? My dad's only 67. He has no idea how to email still. School starts at, elementary school starts at 7:50. Middle school starts, my son has to be there by 8:50. So does high school. Bear Lane is way over here on this side of town. Think about as a counselor.
That's also a really short period for distribution. From 8 to 9:30 is a really short time period, in my opinion.
I don't know if I could drop my kid off and then come get in line fast enough, safely enough, you know, like traffic and stuff. Yeah, there's all kinds of problems with this. So here I am as a counselor, giving my client a resource. This is a great resource. Mira, look, they'll give you a whole box of food. Here's a whole box of food. Just go. Easy peasy, just go. And that's all I've done is just give them the resource. So what then happens, and let me go back to the slides since y'all couldn't see them. Client is referred to local food pantries to assist with food insecurities and assist with nutrition. And they were like, yeah, I'll totally go. They got the little flyer from you. I'm totally going to go. And they'll set up appointments and do the things. Great. I did my job as a clinician. See you next week. No, I didn't get to go. I'll try to go to the next one. Okay, so that was your due diligence. You checked in with that because that's part of the integrated care that you do. And so you go deeper into the session and you find out like They're feeling super isolated, and now they feel like a burden to their family and stuff, and they're feeling more low lately. Well, that's what we documented before we knew that we didn't really think to delve into. Maybe they had been asking their family for a ride to the food pantry thing, and we can't take you, and why are you always asking for rides? Well, we didn't explore that. Huh?
I've got a question.
Sure.
So would it be appropriate, well, I believe it would be appropriate to at least like do the first half of like while we're in the session, like helping them figure out the QR code and stuff and like pre-registering. I think like the difficulty that I kind of like touched on earlier when you asked us what would best help us is knowing like what's in my power. Especially as a student counselor or like a beginning counselor. I often feel like insecure on like what I'm able to do. And there are times when like I want to suggest a resource or like go further with helping a client, and maybe like others in like the integrative care setting are like, that's not your job. So yeah, I guess like offering advice on like what is in our power as counselors, and what we're able to do to help our clients reduce those I guess negative social determinants.
So I don't even know if I have it in here somewhere or how, but I'm just going to talk about it. Yeah, figure out the QR code. Here's your resource. The doctor told me to make sure that I mention that I give you this thing and that I check in with you about getting this thing. How comfortable do you feel using this resource? Have you used this resource before? It's still a therapeutic moment. It's still within your scope. Unless you have a dedicated case manager on staff who's going to drive them to the thing, it's within your scope. Because I'm going to tell you why. I'm going to tell you why. This is a soapbox I will die on. You're offering them hope. You're offering them connection and care. I have spent many a session like, no, let's figure that piece out. If this is going to reduce your overall anxiety, help you feel better, get you through the next week, why am I going to send you out to work on your deep breathing when this is the thing that's going to get you through your life? We have time to talk about all these other emotions and stuff. Let's let you feel better in your real life in real time. Now, I'm not going to drive you to the thing. That's outside of my scope. But if I can spend 8 minutes with you to show you how to scan the QR code and save it to your phone thingy or whatever it is, I don't know, to get there. And then if I need to help you do a role play to like, how are you going to text your mom to ask her to take you so that you don't feel guilty and overburdened to ask for yet another ride, I'm going to do that. That's also doing counseling in an empathetic, caring way because you're reducing those stressors and you're still teaching skills. I don't know if that helps or not.
That does help. It also like helps me remember to kind of like be creative when it comes to offering resources. Like if the role playing with asking their family members to drive them doesn't work, then we could also think of how to get them to download like the Uber or Lyft app so that they can get a ride that way. Just any way that I can figure out that's within my scope to make life easier for them. I don't just have to like box myself into just, you do therapy, that's your only job.
Well, this is part of therapy. And I'm gonna asterisk this part too, because hold up with, if you're thinking someone needs to go get to a food drive, do they have money to get Uber? Just saying. And if they can't figure out a QR code, do they know how to do an Uber app? Just challenging you. But you wouldn't spend your whole session doing case management work. What you could say is, so that was a really good example for us to walk through of how you might do that. How about you make a little list of people that you could practice that on outside of session? So we did that one together. How about you take that with you and practice that for next time? Because you also don't want to become their case manager, and that's outside of your training, but having that a little initial bump. But this is how we could do that. Why don't you think of a couple of other things? If that one doesn't work, we could do that first one together.
That helps. Thank you.
Thank you for accepting the challenge. Okay. Okay. The more that we get, and I will another asterisk, I guess. I don't know. I'm gonna have the parking lot myself. Social workers can do counseling and counselors. Yes. In the chat, social workers can do counseling and counselors can do social work. But we don't get licensed the same. We just don't have the same training. And that's where I think that stuff like this is helpful to kind of hear and think through that, some of those things. I might parking lot myself, but I will say that I lost my train of thought. Let me back up. Let me go back to my slides. So just thinking, let me circle back. Thinking through these things of when we're preparing the resources and where somebody is. Let me make sure I'm sharing my screen. When we're thinking of, are they in preparation stage before we're offering them the resource, or even before we're offering the skill? Say they have anxiety and they have a really hard time advocating for themselves, but they need to talk to their doctor in an integrated setting about their medication management. Right? Where are they within this? Is it really hard for them? Do we need to think through, are they in preparation stage, contemplation stage? Is it hard for them? Do they have access to the doctor? You know, just thinking more broadly about their stages of change in regards to their SDOH. Maybe they've never used one of these services before. They don't know how to, don't have access to, etc. And thinking through these things can help us when we're looking at, are they hopeless about life gonna die? Are they gonna kill themselves? Or are they just hopeless about the system and trying to navigate it and get their basic needs met? This also gives us more depth and breadth to the services we're trying to refer them to and how we're trying to think of their mental health care. And y'all already saw this. Okay. Itty bitty story time. So again, yesterday trying to get the, I knew there was flyers for, there's always, oh, that was the Corpus Christi, whatever flyers that I found. So scrolling through, I'm never in that group, right? But I knew I wanted an example for you guys that was fresh. I also came across something that really made me upset, and I think comes into who was asking about more efficient way of finding resources and connecting clients to resources. You will find, no matter where that you work, that there will be often a list of available resources. Someone has already created a list of available resources. Is that true? Within a hospital setting, within a juvenile setting? And how comfortable, scale of 1 to 10, 1 being not at all, 10 being pretty good, how comfortable do you feel with that list of resources, passing that out to your clients? Put in the chat. A 5, 7-ish, 10, 8, 4. Oh, where are my case managers at? X case managers. Oh, hi, I want an app. Six. I remember at times some people would say the resource is not valid. Our calling app. Okay, y'all write that down. Somebody remind me to look at it later. A 4. Y'all, if I have depression, or even say I have postpartum, okay? Or I have anxiety, or anything. Let's say I have anything mental health related that impacts my ability to make decisions or to think more than 5 thoughts in a string of thoughts, right? Depression can look like not making clear decisions consecutively. It can be like a hard time to finish steps and actions. Anxiety can look like overthinking, hesitancy to do things, to get things done. just, to run the gamut. I have to build up energy and strength and the will to make a phone call, to call a therapist's office to get help. If I'm co-located with, say, a therapist, and I need to make a phone call to a cardiologist or something, or if I have to call for food pantry help or whatever. If I have depression or anxiety, it's going to take more than 1 or 2 steps. I don't have any current mental health issues besides just being super stressed out and like tired all the time, right? Kind of typical, normal mom, businesswoman life. But I'm still like, oh, I gotta call people. Okay, I'll make a call, right? So someone who has mental health needs, it's hard to make those calls. I was checking for my case managers on here because y'all who are really, really secure in what y'all's lists are need to be double checking them. Y'all who are students, you need to be asking your site supervisors, when is the last time somebody updated this list? And I don't mean when's the last time somebody updated it, like added a name to it or took off an old name. I mean, did they call the numbers on there and Google the street address to make sure that that was still absolutely legit? This is another soapbox I will die on. I was on the Facebook group looking up the little pictures for the food drive for y'all, and I legit saw these pictures, and I got so mad, about to go off on somebody. Can y'all see my screens? This list is so old. Pobrecita mom just asked, like, hey, I got this list from somebody. I don't know if it was from her doctor. I don't know who she got it from. Can y'all help me pick which office would be best for my kid? That's what the mom Facebook groups do, right? I got a list of counselors from somebody to find counseling for my kid. Y'all tell me who's best. That's what we do as moms. I don't know what y'all do, but moms do this. Y'all, half these places are closed. Half these addresses are wrong. I am so mad I'm about to stab somebody. Oh my God, I'm being recorded. I don't mean like that. I just mean I'm so frustrated. I just mean I'm so frustrated at this point. I mean, they posted anonymously. I did reply to them. Hey, if you need extra assistance, please let me know. Unfortunately, this list is super outdated. I'm a local counselor. If you need extra help, DM me. I only treat adults, but let me know and I'll get you some fresh resources. This list is old. This mama got it from somebody with their whole chest, got this list. Here's some resources. And I know y'all, those of y'all who are students, are taking these lists with, like trust and confidence of like, okay, I can take this, maybe I can add to it. So those of you who do have maybe professionals who work alongside you or who have a dedicated administrative assistant who can spend that time doing that, or who would have the support of your site supervisor to say, look, I can't see the next 3 clients because I have to find resources because your list is old and raggedy. Then this is what we got to do. This is part of the advocacy component of what we do as counselors, is saying like, we need to carve out the time. But I'm going to pause for a second. My ex-case managers, can y'all speak to this for a little bit for some of our clinicians in the room or clinicians in training who've never had to experience this, or maybe tell me to shut up a little bit.
Hi. So I was a case manager at MNJD for a little over 3 years, and when it came to like specific resources, it was difficult because we had the like exact same sheet of resources that Dr. Salazar displayed on the screen a while ago, and half the time most of those were not valid. But because of the workload I had, like I didn't have the time to sit down and actually research and update these resources. And so it was very frustrating, especially to families that were needing those additional services or additional resources to help them out. It was like very disappointing to them. And also, I don't want to say dismissing, but like they kind of felt let down because they're like, oh, like my case manager is going to give me this list of resources that are supposed to help me. Now they're calling these resources and they're just being met with nothing. And so I remember it was very frustrating at that point. And then not having someone like have the time to update that list for them or be able to provide anything new for them that was going to help them in like their certain situation that they were in.
Yeah, so it's a systemic issue. Again, soapboxy a little bit. It's a systemic issue with systemic needs problem. And part of the thing that how do we find a more efficient way to find resources is we have to advocate from within and say, my client needs these things. Who is going to help me find the resources for them? And to put your foot down. And I say this with all the privilege in my chest of being a whole doctor and that I work for myself and I can say like, no, I'm not going to do that. Like y'all need to find somebody and all those things, but really being firm and saying, if you want me to keep meeting with these people and they have these needs, you need to get me updated resources. And you need to carve out the time. I'm already not being paid. So as a student, most of the time. So what do I do? How do I help here? And you can piggyback off of other things like there's an app that was mentioned here. So is that more of a national app? Is that a local app? So finding some of these bigger resources can sometimes help. Something like 211 is a statewide app, for example. 211 is also a website. 211.org is a statewide resource. That's something that as a clinician, y'all can use to kind of play around with. Get yourself familiar with this tool, just like you would get yourself familiar with a bunch of CBT worksheets or like breathing worksheets or something, because you have to kind of get used to like how you can filter it. Like I typically don't recommend clients go to 211 just on their own. I might pull it up on their phone with them or pull it up on the screen with them and kind of filter with them to find a couple of options. That one's typically pretty good and updated usually. It's at least got the most updated phone number and address, usually. But play with that one as kind of like a learning tool of where you can narrow down a bunch of resources to start with.
I got another quick question, Dr. Salazar. Yeah. So I'm sort of kind of responsible for making the new updated list for one of the practices that I'm interning at. Mm-hmm. What are the different aspects that should be mentioned on a resource list?
Updated location, updated phone number, mm-hmm. Contact person, not like this one has like, I'm not going to say her name, but like she's the director. She doesn't do any counseling. Like you want to have to contact the front desk lady.
I know that aspect, but I mean like, what kind of resources, like what categories of resources, like licensed professional counselors, psychiatrists, clinical mental health agencies, what else beyond that, like food assistance programs, disability programs, what other kind of things could I include?
Like if you were in charge of a list of resources, what categories of stuff would you put on there? Yeah. Oh, I'm sorry. I usually have national resources, like on my website, I have a category for like free therapy services, like therapy for Black girls, the Alejandra Foundation for Latina populations, it's like free counseling stuff, therapy for Black men, things like that. I have the Trevor Foundation, so like suicide and low cost prevention sources. I also have psychiatry, food stuff. I used to have a childcare, but it's so full that I don't even bother with that anymore. Let me see. For my list, I also have the Universal Unitarian Church, because in my practice, we are inclusive of all identities and beliefs. And so that's a very welcoming, queer, LGBTQ friendly church. So I have a little category for that. Pride Center. So I have an LGBTQ/queer friendly category.
Okay.
I think that's it.
All right. Yeah, I added like group specific resources. Like,
yeah.
Okay. Thank you.
Yeah. And then that stuff right there. Legal assistance, yes. Legal assistance, just Rio Grande Valley is the only one that we have right here. What's it called? Rio Grande Legal Aid is the name of the thing, of the practice. They're the only one we have for the South Texas area, but that's like one bullet. And I always make sure I put a little star next to it of yes, yes, thank you. Texas Legal Aid is statewide. The one for our area down here is the Rio Grande region. Who's texting me? They need to wait. I think Gemas. Anyway, so I went off. Let me circle back because I went off on a tangent last night. So upset that this list is still going out. I'm pretty sure I've seen this list a couple of times. I know on the second page, 3 of those offices are no longer open. Just my heart goes out to this particular mama, but just to all clients trying to get help and assistance, and just trying to make a decision, finally reaching out for help, and like help me decide which one. Well, Nana, like I don't know none of them. So just kind of being the advocate. I don't have a way to make it efficient. It takes time. Sorry, I don't remember who asked. It takes time. A lot of places may not have the staff to call you back right away. And even if the website is up to date, I still want to make a phone call. I want to know, because I talked to somebody, are you taking clients? Is there a wait list or not? Especially with some of those, if you work as a case manager, which a lot of people do once they first graduate. Is there a waiting list or is it full until 2026? Should I even bother making that referral? They closed Nueces County Social Services Office. It's closed. Like, yeah. Right. So just, it's not easy. And one of the things that you can do to make things more efficient is to be a good community advocate where you do work and to make good community connections. So if I don't know where a resource is, I talk to Orlando over the Pride Center all the time. I just saw him this morning at a different event. Orlando, can you help me find a thing? Right? I have a queer client and I need help with a thing. He's going to know. So that, for me, is the most time efficient way, or I can text him, more than keeping a list. Yeah. And do they have funding? Because some things have funding cycles. The statement was, do they have the funding right now? So there can be a program, but does it have funding every year? Or what are the cycles for funding? Some of that is very, very nuanced, and you're not expected to know that within your scope as a counselor. Within your scope as a counselor is to know, is it even still open? Is it still legit? I don't want to put all of that burden on you, but just, is it even open? When someone hands you a list at an agency, wherever you go work, or wherever you do your practicum or internship, or you get a new job somewhere, say it's even 10 years down the line. Oh yeah, here's our list of resources in case you have to refer somebody out or whatever. Okay, I want to know who updated this and when, and how do they update it? I am not giving this to a client unless you tell me those things. Don't put my name on that. Ooh, that was real salty. I'm just saying. Because I would rather go through the trouble as a clinician, as someone who's seasoned, I would rather go through the trouble of helping them Google and make one phone call in my office to find a number than to give them a list and have them be distraught and feel hopeless and helpless of digging through a list that's worthless. And soapbox, let me see what else I have on my slides. Dr. Mata, y'all might have called the wrong person to come do your presentation. Okay. I'm salty up in here. Uh-oh, I went backwards. So how does this, so as a clinician, when someone is in preparation stage, there's kind of a little bit of connection that we need to help them make as a counselor. This is more counselory skills, right? If someone's kind of preparing and I don't like these graphics that I chose. I don't like those. But go with me. When they're in preparation stage, like, yeah, I know I need to kind of think about those things and I'm trying to do them. They're going to need more clinical support. They're going to need more psychoeducation. You need to really normalize, like, it's fine to get help. What are those barriers? What are your emotional barriers? And really just digging into some of those pieces of what they're thinking through from whatever orientation you're thinking about. And if they're in contemplation stage, y'all, if they're just like, maybe, trying to give them an immediate referral may do more harm than good. If they're not ready for it yet, keep pushing for giving them a referral may not help. A referral for anything, any kind of resource. You still may think in your clinical judgment, you would still document it. You would still say, I'm going to refer you to your church, or I'm going to refer you to wherever, food pantry, whatever. Even though your integrated team is super focused on action steps, they need to get housing. They need to get this thing. But having them make any reliable change in the contemplation stage is so difficult. It's just really hard. They're not ready yet. There's, some problems with following through. And this could be because of their symptomology or because of access to care or because of the SDOH. But this is where a lot of clients can fall through the cracks. And this is where I feel like the counselor can really help the most. Because you continue to support, you're addressing if they have the shame or the emotional things, offer the coping skills to think through these things that they need to do, that they're telling you they need to do to get on with their life or to get forward through what they're going through. And this is what I mean by coming to the client with prepared options instead of just that referral list that may not go anywhere. Maybe coming to them with one thing. Here's the one option that you could choose versus a whole list of stuff, and talk through what would help them get through that one step. Just make the account to get your SNAP benefits. You don't have to apply for SNAP benefits. Just make the account first. See how you feel about that. SNAP is food stamps. Get your SNAP benefits. This is important because if they're not ready, it's just this verbiage of non-compliance that we see in integrated charts, and this language of like failure to follow through. For me, really puts a lot of negative blame on the client. I used to see this so many times in the psych hospital, inpatient, inside the psychiatric hospital, of like, patient's non-compliant. Well, I mean, did you talk to them about all the stuff? Did you ask them if they were ready? Did you help them understand the barriers and some of the shame and some of the guilt instead of just saying they're non-compliant? Rude much. And if that's kind of the perception that's being put inside this integrated chart, then that's what everybody is seeing when they're working. Every person who's touching this chart is seeing this perception of this individual when they're trying to work with them. So us just showing a little bit more compassion and a little bit more intentionality of helping them when they're in this pre-contemplative and contemplative stage can really help them to build that resilience up they need, that access to care they need, and to increase their potential ability to go through the system and to not feel so overwhelmed with all the things and decisions they have to make. Sometimes it's a lot. I don't know if y'all have ever seen, if you print it out, I'm just going to say, if y'all printed out the food stamp application, it's like 42 pages long. It's long. And they ask you like 8 times if you have children. Even if you have no kids and you can't skip it. It's like 42 pages long. Dana's laughing at me. It's long for no reason. Can you imagine? I'm depressed and I can't get out of bed and I'm like, oh my God, I have to fill this thing out. And it runs in Flash. Oh my God, you have to do it on the desktop. It's so annoying. Yeah, It's hard. But clients are labeled as ambivalent because they don't want to do it. And we have a lot of power to advocate even through our documentation of how we talk through clients. Through clients needs. I want to impress upon you. Am I sharing my screen? Okay, good. Working to manage, address, and overcome as your job as a counselor.
I don't think you're sharing the PowerPoint.
I know. I'm sharing y'all's faces. Thank you for telling me that time, though. Now I'm sharing the PowerPoint. When you're working with a counselor, if client working with a counselor, thinking through the SDOH and kind of how they need to get their needs met in integrated care, your job is to help work with them to manage, address, and overcome their emotional behavior and other intangible barriers to meet their daily needs. There's sometimes, not every client, it could be varying pieces of all this stuff, right? The guilt, the shame, the fear, the avoidance, the isolating, negating needs. Oh, I don't need no help. I'm fine. All this stuff. And sometimes I just can be very direct with them. I hear what sounds like shame is what gets in the way of you asking for help to afford food. Or whatever emotion that I'm reflecting for them. It's just a reflecting. Or use a door opener. I don't care. I don't care what basic skill it is that y'all use. Pick one. Except a closed question. Don't do that. Because that can be shame building in itself. Did you go get food? Did you go get the resource? So I just don't recommend that one. But what would it look like if you did go ask for help? I'm curious what it would look like if you didn't have any shame or didn't have any guilt about going to get that service. And I've been focusing a lot on the services, but what about some of the other social determinants of health? So even their neighborhood or where they grew up. So I'm really curious. We haven't talked about it much, but I'm really curious because I'm hearing a lot of shame about you talking about going back home to your neighborhood. Let's talk about that. Just opening up that SDOH, that breadth of stuff of categories. Because those are different, those will be different reflections kind of depending on what your theoretical orientation is and how you're going to go there. But just curiosity, and that's still some of the stuff that you're working through, some of the guilt, the shame, the fear, the avoidance, navigating some of those needs. You're thinking through these management and addressing and overcoming that stuff. But overall, when you're really thinking through these things, you need to think about accessibility, reliability, relatability. Just how I challenged y'all earlier, like if you need a food pantry, can they use an Uber? Make sure when you're doing referrals that they're up to date and active. I think I must have written this draft before I found those pictures on Facebook because it's the exact same thing that I was going to talk about anyway. Don't refer out to something that's a dead end resource. It's so much better to say, I'm not sure. Let me consult with somebody. I'll get that to you by next session. I say it all the time. I don't even know if that place is still open, but I'll call them and find out. And if I can't call them, I'll let you know. I don't know, but we'll find out. And is it culturally responsive and culturally appropriate? Do you need a Spanish speaking space? I actually, I was at an outreach event this morning and I'm a no sabo kid. Like I barely speak Spanish. I'm taking Spanish classes right now. But the grandma was asking me for Spanish speaking counselors. And so we were trying to talk to each other back and forth. And I had a student with me who's onboarding and she's like, why didn't you just tell her to come to us? Because I don't speak enough Spanish. So I was trying to get her to like the counseling training clinic. I'm not going to refer her to me. That would be culturally inappropriate. I'm just saying, like, don't just pay attention. And does it actually meet the need that they're describing? Because sometimes they say that how do I say this? Does it actually meet the need that they're describing? When I was a case manager, I don't know where Crystal went. She was a case manager. This is another piece. I don't have a slide for it, so I'm going to talk it through. I meet with clients. I don't have it. Let me back up. An assessment, right? I think about food all the time. And the assessment where I was working at was trying to get to, do you have eating disorders? I obsess about food. I think about food. I try to hoard my food, things like that. And we saw a rise in the number of students who had eating disorder related issues or eating related issues. And I was like, hold up. We work with poor students. Are they hungry? Do they have access to consistent food? So are we even asking the questions in our assessments when we're meeting with clients? Are we asking for what they actually need? And are we referring to what they actually need? Because as soon as we clarified, are you thinking about food or do you have access to food? It started evening out again to where statistically it was more equitable to like what eating disorders really are for the age group that we were looking at. It was like, there's no way everybody has an eating disorder. But it made a lot of sense that a lot of them didn't have access to food. I don't know, helpful, not helpful, that piece. Even helpful thinking about our assessments that we're doing. Oh, we think we're a clinician. Let's just throw some assessments at you. Which one? And por qué? Why? This one right here is going to drive some people crazy. And this is hard. As the counselor doing the referring, if I have given you the resource that maybe you should go follow up with this thing, follow up. Don't just jump in next session like, oh, you said you had a problem with food. I'm going to send you to the food bank. Don't jump in next session like, how'd your homework go? Okay, let's talk about the next thing on my treatments and interventions list. No, follow up. Circle back and document it.
Does this also apply in situations where like, I know in agencies where like sometimes you'll only see a client once or twice?
If you touch that client again, and it's within like return to center the next week and they return to center the next week, ask them, how did that go for you? And document. I know it's hard, but if you never see them again, then that's different.
Okay.
And I say that because it covers your tush. It covers you. The hardest thing that you may find that is most time consuming is consulting. I don't know, but let me find that resource for you. It feels easier to just Google it and find it for yourself. Trust me, after 14 years of doing this, it's not. It's not faster for me to just Google it and find it myself. Consult. Get to know a couple of experts and just call them up. Hey, do you know somebody who does a thing? A couple of people that you trust. Or a couple of people who you know who do update their lists and stuff. I know it sounds like a lot of work. And that's when you come back and say, I'm not so sure, client. Let me consult with somebody and I'll get that back to you. And then get on with your session. I wanted to make sure I left time for questions, but this might be too much time for questions. My prepared stuff. Let me look at my list, but let me see. What are your takeaways, thoughts, questions, concerns? I'm sure y'all would love to leave early, but let me see what we got. Let's start with questions. Buddy, which is fine. So how often would you verify numbers and referrals given out to patients? I typically do it twice a year because that's all the monthly would be overkill unless it's a very specific type of resource. And I'm waiting for an update. Let me give you an example. The housing waiting list is always astronomically long. And so is the childcare assistance list is always astronomically long. And I'm talking like literally right now, I think it's 2026 is when they're going to open it again. More or less, like maybe late 2025. But the waiting list is that long, but they're not going to open it. They'll just open it real random. Now you can add people to the list. So like that, when I was a case manager, I would check it like maybe once a month, every 6 weeks, just to see what was open again. But for other stuff like local counselors or psychiatry offices and stuff, that I would do like twice a year during my quote slow periods, which is summertime for private practice. Typically tends to be slower. And then that period when I get burnt out, which is like right before the holidays, where I kind of don't want to see lots of clients. I just kind of want to veg a little bit, but still be in the office doing piddly stuff like admin stuff. So I do it kind of during the summer and during like that period. So twice a year. I'm also real lucky though this year because now I have 2 students coming on board with me. So I'm gonna have them do it. It's a good learning experience. Sorry, but none of them are here. So, but there you know. Let me see some of these things that y'all put in here. Some of the stuff that we put in here is really good if y'all were taking notes, like things to put on your referrals list, like not just like the phone number, location, and the categories, but making a note like, is it faith-based or not? Some people, when you're thinking about incorporating spirituality into some of their needs, people only want to go to a counselor who's faith-based or only want to go to a social service that supports faith-based whatever, or workout group or a women's reading group or something. They only want to go to faith-based things. So stuff like that. A lot of places do not allow felons or sex offenders to use their services. It's actually something that I got another soapbox on too, because like my colleague sees children. So since I see adults, I cannot treat sex offenders or former sex offenders because there's children in the building. And they can't have virtual services because sometimes depending on whatever the stipulations are that they have, they can't have internet, right? And so even if they wanted care, they couldn't get care here. Not that I have training in that, but that's just a limitation to care. So even if I had different schedules and stuff, like the card is behind us, so there's still children in the building, all kinds of stuff, and that really limits that place of care. I saw Crystal nodding. There's very little places that'll hire persons with records of felonies. Like I know Little Caesars does, but that ain't enough money for nothing. Insurance is a big thing. Oh, do you need an ID? Oh my God. It's so hard to get an ID if you don't already have one and don't have the paperwork to get it. It's so hard. You must. Oh my gosh, when I'm reading back the comments right now, just when I'm thinking about referring to food services, which is one of the biggest things right now because grocery prices are sky high. I can't even. I'm so glad my kid is back at school. Just personal note, food's expensive. Is it culturally, can you cook it? Can you eat it? What if you have dietary restrictions? The example we used was diabetes, but oftentimes when you see stuff at food pantry drives, it's high in sodium, it's prepackaged foods, it's very little fresh. Or if it is fresh, it may be like on the verge of expiring, or it's, you know, kind of already there a little bit. And the cheap stuff like ramen, sure, but there's so much sodium in there. And the example has high cholesterol. Is that good? Probably not. I'm not that kind of doctor. That's probably not the best. Let me go back to my PowerPoint because there was something else that I wanted to touch on. Oops, I lost y'all. If y'all have more questions, y'all can think about it. Sometimes, or not sometimes, the way I have my intake set up, I use something called therapy notes. So I have a pre-built in intake form, but I also have a Word document that I keep extra notes on, and I will integrate it into my biopsychosocial assessment. And I'm not on that computer, so I can't show you all the Word document, but I have additional questions built in because I ask about SDOH. That way I can build it into their treatment plan if I need to, or just be informed about some of these things. So I'm not just asking about their family, like how many siblings you got, how many kids you got, are you still married, are you still divorced? I'm asking, what was life like for you growing up? How comfortable were you financially? Did you feel like it was a struggle? If y'all even talked about financial concerns. And usually that brings up a whole slew of conversation during a biopsychosocial. And that helps inform me about some of their SDOH without me having to dig when there is a problem. Because even in integrated care, it may never come up. But if you cover it in the intake, for your spirituality needs, what does that look like for you? What does support in that area look like for you? If you are religious or spiritual, I wish I had that laptop with me. Let me try to, oops. Let me share my screen again. Share my PowerPoint. Are y'all seeing my PowerPoint? Okay. I'm gonna be so paranoid now. So within my intake, again, I have categories like this. So I don't have it labeled economic stability, but I have it labeled like lifestyle, and I just add it into my intake where needed, because not everybody has this kind of stuff, right? So are you currently employed? What has your employment been like before? Are you happy with it? How happy are you with it? What's your income like? I don't ask about debt or medical bills, but I just say, how comfortable do you feel with managing your income and money coming out right now? Money going in and money going out right now. It's a little less intrusive, but I'm still asking about it, because if I'm not asking about it, they're not going to tell me about it unless it comes up some other way. How safe do you feel where you live? Who's all in your house right now where you live at? Do you live by yourself, with family, with friends? How comfortable is that for you? So it's still all the same stuff inside my intake form, my biopsychosocial. It's just how I'm asking about it kind of expands that worldview into including this SDOH. When's the last time you've been to the doctor? How comfortable do you feel going to get medical care? This is especially important for historically excluded and marginalized communities. Oh, I don't trust no doctors. Okay, noted. That's going to make it especially difficult for me in the future if I need to refer you for psychiatric care or cardiac care or diabetes management. But I've asked it in the intake. What was school like for you? Was it easy? Did you get along? Questions on that? I know there's a lot of students in here. I know as students, y'all don't have a lot of wiggle room in any of the documentation that you have, but even the way that you phrase the questions, y'all can have some leeway as y'all develop your own inner scripts, and how you get comfortable kind of bringing up these topics, just being more inclusive of not just like who's in your household and checking the boxes, but adding and how does that feel for you? Is that okay for you? The intake is the one place where I love closed questions. Just yes or no, kind of tell me, and then I can expand where we need to. Let me stop. I'm going to get off the soapbox again. Bethany, Sharon, help. Where are we going? What else do we need?
Yeah, here, I'll help you,
Okay.
cut the dead air a little bit. I'll throw you a bone. Yeah, just understanding how like a sense of belonging and like that community support is like one of the most important like social determinants of health. When it comes to like a situation where your client does point out how they would like to improve in that area, right? And you continually provide resources to help out with that. At what point, or I guess, yeah, just I would say in my experience, I would, one session, okay, I introduce a couple, the next session, I introduce a couple more, and I'm following up to see if they're actually using any of these resources. And then they're not. And so I guess I get kind of torn on like, all right, do I pull back a little bit then and be like, okay, well, what's it going to take to get you to actually show up to one of these things? Or do I keep just throwing out as many suggestions as possible, that might finally get them to go, get engaged in one of those?
The easy answer, without hearing a tape, without looking at the case conceptualization, without knowing orientation or anything, is to challenge them and say, look, you're asking me for this thing and I'm giving you the thing. Let's look at what's getting in the way. And then silence. Okay. And then go, that's the easy without going through all the other stuff. And that's really hard because you're trying to help them, but you can't keep throwing stuff out there. It's like just like throwing poo and letting it stick to the wall, but it's not going anywhere. Let's look at what's getting in the way.
And that's kind of what I meant by too, like it just not being fruitful whenever you are like spending that time to look for the resources, right? And it's just like, why, why are you even bothering? Because you have other clients too that might have, you could spend time researching on that, and it's unfortunate that like that research on like trying to pull up more resources and stuff kind of gets put on the back burner because of that.
So then what you're looking at is what stage is your client actually in? And you've offered the resource, right? And so now you got to think through, okay, so what's the barrier to get you through the next stage of change to actually have those resources be effective? So work through those stages to see where they're at. Because if they're in pre-contemplative or kind of contemplative stage, then that's why you're feeling like this is useless. You're working harder than the client.
Yeah.
Hard stop. So challenge them. The other thing that I'll also do is, okay, well, you pick one, bring it to session, and then you and I will figure out in session, how do we get you there? How do we talk to the emotions to get you there? Yes, no. Yes, no. Good, helpful. You're working harder than the client. Stop.
All right. I got a bonus one for you too. I'll help you out some more here. So, and I guess it's kind of like a psychoeducation question too, but helping a client realize that they are beginning to isolate themselves.
Ooh, I'm gonna hard stop you though, because you can't help the client. You said it like you want them to do what you want them to do.
Well, in this specific instance, it seemed like symptoms or whatever they were going through were starting to get worse as they were kind of pulling away from people, pulling away from like their support systems.
Curious challenging is one of my favorite things to use. One of our former professors, lovely Dr. Smith. I'm really curious about that. I wonder. So how that works is I'm really curious about you staying home a lot and withdrawing, and what it looks like on this side is we call it in counselor land isolation, withdrawing. Let's go there. Tell me about it. And then silence. And let them go there, right? Because we want to tell them the things, especially when we see these, if we're considering the isolation and like social determinants of health and like referrals and what we think they need and like their life and stuff, we want to tell them the things. We want to fix it. Because if they would just get out of the house more, if they would just move their body more, if they would just listen to the doctor and take their blood sugar, if they would just go meet up, hang out with friends, then life would be so much better, right? So just be curious about it and challenge where you see a discrepancy in what they're telling you and what they're showing you. And if they don't want to do it, they don't want to do it. I can't force anybody. Yeah. And we cannot work harder than our clients. That is the fastest way to burn out, period. And it depends. Bethany's laughing at me.
I think that's everyone's favorite answer. I've had an astounding response from students saying like, that's the worst answer ever, but it's the truest one. It depends.
I know. It's the worst, best, most universal answer. Let me double check my list. Can't read half my own writing. So did I miss something? Takeaways and what was helpful or not helpful about today. Some feedback.
I think you did an excellent job addressing the concerns that we had and answering them in a realistic manner and actually helping us like implement the lesson that you taught. It wasn't just like teaching. I'm actually able to know what to do, and I can start the semester feeling a little more confident and capable of carrying out these conversations, especially with like healthcare professionals that are maybe more like advanced in their career than I am. I'm actually a little more comfortable with being able to have that conversation. I had a question on like when we're addressing these social determinants of change, let's say there are like three major ones. Like how do we go about like addressing which needs first? I know it's also an it depends kind of thing, but
I was trying to not give you an it depends.
Yeah, it probably depends on the client, right?
Well, safety.
Yeah.
Safety is always priority. And then I always go within safety, like medical over mental, unless the mental is safety involved, like harm to self or others. Because medical is safety. But outside of those, because sometimes it's other things, because it depends.
Okay.
I try to go with what's most realistic and accessible. If like the housing waiting list, for example, is the 18 months long, or childcare list is 18 months long, I'm not going to say go do that first. That's the most defeatist thing. But maybe I can get them over to Coastal Bend Wellness and they can get some diapers today.
Yeah. Okay. Thank you.
But definitely safety first, and then medical over mental, and then what's most realistic.
Okay. Thank you so much.
Mm-hmm. And I'm glad you found some good going into the semester. I'm not going to force y'all to talk. So if Sharon or Dr. Mata and Bethany are okay with wrapping up or waiting for another question or so, it's up to y'all. I'm at your command. I love teaching, so it's up to y'all.
I mean, I think as long as the students have questions, like please, I know we've been here since 10 a.m., but we had an hour break. So hopefully, if y'all have questions, this is your time to ask them. We have Dr. Salazar here. I think we've only had you like a couple or a few times this, like in a year. So this is your opportunity now. But I think if not, Sharon, I think we're good.
Yeah. If no one else has any other questions or comments or anything, yeah, we can definitely wrap it up.
For some reason, this draft of this version cut off my resource list. I switched offices this morning doing outreach, but if anybody had any further questions or anything, I'll drop my email in the chat. Did I do it right? Yeah. Y'all are always more than welcome to contact, reach out, and consult. I can never promise or guarantee that I have all the answers, but I definitely will consult with somebody else if I need to. It's always a pleasure to come speak and teach. So
Thank you so much for being here. We really love to have you here.
Yes, thank you.
For those of you who were needing CEs, we put our emails in the chat for you to reach out to us, and then yeah, for the rest of the students, we'll see you, or we'll be reaching out for more other things Texchip related.
Yes,
But other than that,
orientation's on the 31st.
yes, orientation is on the 31st. And yeah, have a good rest of your weekend. Thank you so much, Dr. Salazar, and I'll be seeing you. We'll be seeing each other. Bye.
bye.